Good morning, members of the public. Good morning, committee. Welcome to what I believe is finally the last interim committee meeting for the Joint Labor, Health, and Social Services Committee for this interim. We ended up with one more meeting than we thought we were having, but we are only taking on one item today, and that is to make our final address to the Community Behavioral Health Priority Populations 21 LSO 225. Katie, if you would call the roll, please.
Madam Chair, John Brody, LSO. I'll be calling the roll today.
Oh, okay. Go ahead, John.
Senator Baldwin.
Here.
Senator Bouchard. Senator Pappas.
Here.
Senator Schuler.
Here.
Representative Barlow.
Here.
Representative Clem.
Here.
Representative Dayton Selman.
She was here, just didn't time her speech with her mute button.
Representative Hallinan.
Ditto.
Representative Roscoe.
Excused.
Representative Stivar.
Present.
Representative Sweeney.
Here.
Representative Yin.
Here.
Co-Chairman Scott.
Here.
Co-Chairman Wilson.
Here.
Madam Chairman, we have a quorum.
Okay, super. All right. Members of the committee and those of you, welcome to, we have a few of our future members on, welcome. We heard the presentation of this bill at our last meeting, but owing to its size, the committee decided to bring ourselves back for one last meeting, hopefully finishing by lunch or even before. The source of this bill was the assignment of management council to set up a joint committee from labor and appropriations. So we had 2 members from House Labor, 2 from House Appropriations, 2 from Senate Labor, and 2 from Senate Appropriations. And we met, I don't really recall, 4 times or maybe more. I think that's a 4 that Representative Larson is waving at me. Representative Larson is also on, and he was the House co-chair. And the purpose, as assigned by Management Council, was to really look at our community mental health / community behavioral health programming and evaluate, in light of our criminal justice reform bills, in light of our budget challenges, just in light of the general situation in the state, what would be the best way to prioritize the populations for the general fund money to our community behavioral health programming. So that was what we did. This bill is produced. And just from the 30,000 foot level, the main goals were to prioritize the ways in which these mental health programs would serve people for the general fund, not specifically speaking to other things that they might be doing in their work, but for the general funds. And it does have at the end direction to kind of carry on and flesh this out a little bit further in statute. So members, what I'm just going to do, really for my own benefit as well as for yours, because we'll have to run this bill in the coming session, or at least I hope we get to run it. I don't want to say have to, I hope we get to. And I'm just going to kind of go over at a high level, then I will ask Representative Larson, who knows the material even better than I, to flesh it out. And then if we've got any LSO comments, we'll address those. I will remind you the same thing that I reminded you at the last meeting, which was that because this was an assignment from Management Council to the joint committees, I would hypothesize that if we don't run this bill, appropriations will run it. And we maybe won't like how they do it if we don't do it. So just my caution there. So the first page, of course, is all the usual stuff. Page 2, we have the definitions, and we're just adding something that has been standard in the behavioral health field for quite some while now, to call these clinics behavioral health centers instead of mental health centers. So that's, and you'll notice on page 2 that those definitions are in Title 25, which is the section that deals with the involuntary commitment, not specific to health department or anything, but the actual involuntary commitment. Page 2, again, it's in Title 25. And let me just pause here to say, so we have, you will have noticed, we have quite a number of amendments, mostly cleanup amendments. There were some things that we discussed a little bit in our last meeting. I'm not going to address those at this time. I'm just trying to remind people of what we looked at last year. Page 4, bottom, just indicates here we are now in Title 35, which is the health department area, talking about serving priority populations, and that's where we got into what the whole goal of this bill was. Page 5 is just some cleanup language to use more common language. Page 6, we begin to identify the category, to define the categories that we are going to refer to later. We had discussion on the bottom of page 6 about acute mental illness. You'll see that I have an amendment to flesh that out a little bit. We've got page 7, families at high risk, and there is a Roscoe amendment fleshing that out. Page 8, we talked about the indigency. We may have some discussion about the federal poverty level that we want to put in that category. Skipping over to page 10, now we list, okay, this is what priority population means. And again, these categories were based on the work of the joint subcommittee throughout the interim, taking testimony from providers, from criminal justice folks. There were certainly consumers of these type of services. Page 11 is just reinserting the cleanup language. Page 14, we are here dealing with, let me just back up. The bottom of page 12, we pick up the powers and duties of the department. That's the Department of Health, the State Department of Health. And this is where we are changing their language as far as using behavioral health centers and how they are going to work with them as far as distributing the general fund money. Page 15 has the tiers of the priority populations, just again based on our discussions in the joint committees, the joint subcommittee over the interim. The bottom of page 15 deals with the topic of providing some sort of subsidy similar to what the small school districts get when you're dealing with very rural areas that might potentially not have the population size to provide services if they were only providing to the priority patients. So we want to make sure that they have the capability of carrying out those services in general. Pages 16, 17 really just deals with the types of the contracts and mostly adds some changes to the language. Same with 19, we're really not changing any of that. Page 20, we do have some repealers. And those of you who are, we have, I think, I'm not sure if we have a few new legislators listening in. When you begin to look at bills, the repealers are always something where you need to look up ahead of time, because all they just list ever is what sections of statute are being repealed. And unless you look them up online or in your statute book, you don't know what they are. And it's usually good to find out what they are. So those we have on page 20, line 8. The first one is requires for comments on applications, some review language, some confidentiality language, which has been superseded by general law in general. And then 351622, we will have some discussion on that about, and the last one has to do with some private agencies, mostly just cleanup, but as I say, we will have discussion on the 622. And then we have page 21, discussion of what the eligibility requirements would be for the subsidies, a pay for performance methodology. Part of the contracts that the Department of Health drafts basically have, what we might call deliverables, but just discussing what sort of reports and that sort of work they have to do in exchange for the general fund, what we want them to do. Page 22 talks about the case management. There was, we've had some comment in about the top of page 23 as far as reporting dates. If it looks like session will be pushed back, we may feel that we want to change that. And of course, we can always do that during session in our committee when we find out when we meet. So that's my first stab at explaining it. And now I'm going to ask Representative Larson to clean that up for me. And you're still muted, Representative Larson.
Is that better? So for new members of the committee that weren't here, those that were at our last meeting have a pretty good understanding of this, but to just help you understand, this has been a topic of discussion for multiple sessions in how we provide funding to our community mental health centers and that system. And currently we have that coming in kind of a block grant. And as you go through the statutes and ask the question, what is the responsibility then of the community mental health centers? It really doesn't define that in this section of our statutes. And so the assignment that was given to your committee and to the Appropriations Committee was to look at those. And the question that we asked in the subcommittee then was, what is the state's policy? What is the state's role for providing mental health to the citizens of the state? Is it an open door policy? Anybody that wants to come in should be able to receive it, or do we prioritize and in some manner? And we went through several exercises. We worked closely with the existing Community Mental Health Center Association, WAMSAC, in looking at this. And the subcommittee came back and recommended this bill, which, as Chairman Wilson points out, is it's a shift. And we are saying the priority for the state, our policy is that we want to divert people away from state institutions, and we want to prevent them from repeating or any type of recidivism if they're coming out of the state hospital or the corrections institution. But we're really, and people with high needs who have mental illness or those sorts of things. And so we made a list of all those priority populations and then set them in a tier so that when we are appropriating, we can appropriate based on what our policy is, not just what a perceived need might be, which is kind of what we have now. And so with the behavioral health centers, as we call them, we'll be calling them, and we changed that name because that includes mental health and substance abuse, and tried to line that up with the Title 25 definition, is to really prioritize the populations that are coming in there by these behavioral health centers. Now, it's important to also remember that these providers, these community mental health centers, will have a regular business model that they, anybody that they'll provide services and can provide services to the general public. They can take private payment, insurance, they can bill Medicaid, whatever they want to do. But the shift for this will be the state general funds for providing funding to them will be for services that are given to the priority populations. And then this bill kind of defines how that's done. So I don't know that I've said any more than Chairman Wilson did, probably just in a different way.
I think that was good. And especially the reminder that we are not, these are not state agencies that we're talking about. These are private organizations. And as Representative Larson pointed out, they obviously have, and we encourage them, frankly, to see patients for whom they can bill Medicaid, Medicare, other insurances, and that sort of thing, to help them provide services as needed. And of course, remembering that in many communities, there are other providers as well who also can serve Medicaid, Medicare, and other insured patients, or pro bono as necessary. Mr. Brody, do you have anything that you want to add from a LSO point of view?
Chairman.
Co-Chairman Scott.
Madam Chairman, I'd just like to add one item to this bill. I've been trying to do some homework, trying to figure out where we really are financially. And as near as I can tell, that when you go through the Craig projections and some of the other work that's been done, we're currently looking at about a $745 million deficit for the balance of the biennium on about a $4 billion budget. And that, that's what led to the governor to make some really draconian cuts. And I think in managing that, we're going to have to set some priorities, and this bill is necessary to do the priority setting in the mental health area. So I can't emphasize enough, this is the kind of tough decision we're going to have to make as we go through the whole process in the next year. And I think preserve a rational state role in the mental health system, this priority setting bill is essential.
Thank you, Mr. Co-Chair. Mr. Brody, do you have anything to add from the LSO point of view?
Madam Chair, nothing that would improve upon your and Representative Larson's explanation.
Well, very well stated. Okay, then I think so that this is the second time we looked at it overall. We're basically going to deal with the amendments, but I think we may as well open up to public comment at this time. I guess we'll start with the agency. Katie, have we got somebody from the Department of Health?
Madam Chair, we have Franz and also Matt Petrie.
Okay, let's send them in. I see Franz's rectangle.
Good morning, Madam Chairman, members of the committee. This is Franz Fuchs, the Wyoming Department of Health.
Good morning, Mr. Fuchs.
Apologize for the delay. I was on the YouTube and it's a couple seconds behind.
Great.
Stefan Johansson is also in my office here. He has to, I guess, to another meeting with the governor's staff soon. So I'm happy to, we don't have too much that we haven't presented before. We're happy to stand by for questions. I believe some folks in the waiting room, there may be the senior administrator from the Behavioral Health Division, Matt Petrie, if there are any specific questions for that, how things work currently. But otherwise, we're just here at your disposal for any questions.
Okay, you don't have any comments on any of the amendments?
No, Madam Chairman.
Okay, thank you, Franz. Mr. Petrie, have you got any input? Mr. Petrie? Probably the YouTube lag again. Those of us who are of a certain age will remember way back in the day when you'd call on a satellite phone and then talk all over each other. We're regressing in our technology, perhaps. Mr. Petrie, are you there now?
Yes, Madam Chair, I am.
Very good, thank you. Have you got any, if just introduce yourself for the record and if you've got any comments.
My name is Matt Petrie. I'm the Senior Administrator of the Behavioral Health Division. And I do not have any additional comments. I would just reiterate what Franz Fuchs said. Yes, Madam Chair, I am.
Let me just point out that somebody has got their YouTube running in the background. You should turn that off or mute it when you come on to the Zoom meeting.
I'm the Senior Administrator of the Behavioral Health Division. And I do not have any additional comments. I would just.
Okay. Guess we don't have any more from that. Katie, do we have anyone from DFS or Department of Corrections on?
Not at this time, Madam Chair.
Okay, then. Well, then let's go to any other general public. And just let them in whatever order you feel like it, I guess.
There are 3 in the waiting room. I'll let them in now.
Okay. Let's see. The telephone number, Mr. Telephone Number, could you would you identify yourself and for the meeting and feel free to make your comments. Mr. Birkeland, there you go. And you're on mute still. Fear not, committee, by the year 2027 or 2028, we ought to have this Zoom stuff down. Welcome, Mr. Birkeland.
Madam Chairman, sorry for the technical difficulties.
That's all right. I'm just teasing you. Sorry about that. Go ahead.
Quite all right. I am Bruce Birkeland, and I'm the staff person with the Wyoming Youth Service Association, and we do residential treatment centers and group homes and crisis shelters and other early intervention programs for youth and their families around the state. I just wanted to address today that I've talked with Representative Roscoe about a possible amendment that would make prioritize youth that we serve in our crisis shelters, that youth in those crisis shelters that's prior to being involved with the Department of Family Services or in the juvenile justice system. The vast majority of kids that come into the crisis shelters are via self-referral and parents. Their short stay of 12 to on an average of 13 days. They do case planning and discuss how the families can avoid future problems so that they don't have to go further into the justice system. That frequently involves work with our community counseling centers in coordination with, as part of the future case plan of working with those people so they don't end up in out-of-home placements or more severe problems and more costly problems. So we perceive that as an important population to be served and helped with mental health centers. Some of the youth are on Medicare insurance, some can pay, but there's certainly a large number that fit fall into that gap of not having insurance nor being on Medicaid. So.
Good. So
Yeah.
committee, the amendment that Representative Roscoe has proposed that kind of fleshes out what Mr. Birkeland was talking about, what is the last one that's posted on the website. It's not in the LSO format, but it's written up in generally clear enough terms that you can see. We'll deal with all the amendments in order, but for now, that's the one that we're looking at. Does any of you have any questions for Mr. Birkeland? Representative Clem.
Thank you, Madam Chairman. Yeah, Bruce, the only question that I have, and it's something that kind of carried over from last meeting, we're adding, this is going to be page 6, the new language on lines 2 through 7. It's talking about mental illness for these human services programs or under these facilities here. And it's the language about really trying to get rid of co-occurring disorders. I'm not sure if that has any impact or not. I guess that's what I'm asking about. So the language there, the new language talks about, but does not include addiction to drugs or alcohol, drug or alcohol intoxication or developmental disabilities. We have similar language, actually, I think it's in the Title 25 portion of the bill under a similar definition. And we're striking that language in there, talking about co-occurring disorders. And so, and perhaps that doesn't have any kind of impact. I guess my only concern, and just trying to flesh this out a little bit, is, if we're focusing on priority populations, which I think is wise, what happens if you have a person who does have a co-occurring disorder? Does that mean that the substance use portion is not going to be dealt with? And I guess that's where I'm trying to really zero in on, because it absolutely makes no sense just to treat the mental health side of things and then let the substance abuse disorder that's co-occurring go by the wayside. That person will still be in a mess. So anyway, your thoughts.
Mr. Berkland, have you been able to look at the bill itself? Like on page, he's referring to page 6.
Madam Chairperson, I have looked at the bill in terms of changing that piece of the proposed bill and how that would impact the youth we serve. I don't feel real qualified or prepared to answer that at this point.
Okay, thank you. Any other
Sorry.
questions for Mr. Berkland? Okay, thanks very much. Mr. Berkland, if you have time, it might be helpful if you just stay around just in case we have some further questions for you when we address the specific amendment.
Thank you, Madam
If
Chair.
you've got folks to see, though, of course, I understand that.
I'll be available.
Okay, actually, let me circle back because I see Director Schmidt has come on. Director Schmidt, thanks for showing up. Did you have any comments from DFS point of view on this bill?
Yes, good morning, Madam Chairman and members of the committee. I have just a couple of comments. One is specific to the Roscoe amendment. So if you'd like me to hold that until you actually work it, I can. But if not, I can speak just real quickly to some background on the federal poverty level.
Why don't you talk about that now? Because there's another issue dealing with federal poverty level. So it may be pertinent to more than one part.
Okay, well, thank you. So the Department of Family Services works with all families that have some sort of issue with abuse and neglect or suspected abuse and neglect. A lot of the families we work with in a prevention orientation, which means that there hasn't been any court action filed. However, we're providing case management services, we refer to services, and our goal is to work with those families to the extent that they don't require us to remove the children. And the priority population then, and that the amendment addresses, is that specific population. So it's families that come to our attention through schools. We recognize that maybe there's some substance abuse issues, and then we refer and try to help the families work through those issues. In our general population of families that our agency serves, we have a threshold for determining eligibility for a funding stream called 4E. And what that is it's based on 185% of poverty. Of our population, we waver between 25 to 30% of the cases falling in that threshold. So our recommendation is to reconsider the 200%, because the families that we're trying to target are probably going to exceed the 200% federal poverty level, just based on what we know on our 4E eligibility rate.
Questions for Director Schmidt? Representative Barlow.
Thank you, Madam Chairman. So my first question would be the 4E 185 threshold. That covers all the costs that would be associated for those families. That's the first question. The second question is for those families above, does the DFS have a sliding fee scale up to 400 or another level? Or is there no sliding fee scale and it's just private pay? Thank you.
Ms. Director Schmidt.
Madam Chairman, Representative Barlow. So the 4E funding stream only comes into play when a child has been placed in our custody. So 4E dollars are not available to families who were serving in a prevention orientation. They're just an example of the families that we do address. So once they come into our system, then we do the poverty determination, and 180 or between 25 to 30% of the families we serve in care are 185 or below. So we're really talking about a before removal population and an after removal population who's in the custody of the state. The families that this proposed amendment addresses are children and families who are intact and we have not yet removed. And then the latter is, no, we don't have any sliding fee scale. Once a family is court ordered and a child comes into care, there's a court ordered case. The child's services are usually covered by Medicaid. And then we rely heavily on the community mental health centers and substance abuse centers to provide treatment to the parents.
Representative Barlow, follow up.
Thank you, Madam Chairman. So Director Schmidt, so what is the number we need to have? We need a higher number, 250, 400%, or do we need two different categories? One for this 185 below, and then a fourth category under this that says anybody else on some kind of sliding fee scale.
Madam Chairman, Representative Barlow, to be completely honest, I would like to not have a threshold. Because so many of the families that we're engaging with from a prevention standpoint are going to, if we can keep children at home, safely at home, are going to prevent costs once they come into care. So it really is about it's not necessarily about the income eligibility, it's about the client and the family themselves and their needs and trying to get them what we can so that we don't remove. So the goal is really about preventing removal rather than what can they afford. And typically our families, for the most part, are going to be poor.
Chairman Scott.
Madam Chairman, my question is, following on with that, if we have a sliding fee scale or other fee scale in there, does that run the risk that it will be an additional obstacle to working with the families, and some of the families who really need the services will say, we don't want anything to do with your fee scale and simply not get it, and then we'll wind up eventually with a very expensive case in our hands?
Director Schmidt.
Madam Chairman, Co-Chairman Scott, I'm not sure I understood the question. So the question is, does the sliding fee scale help in this situation?
Madam Chairman, the question is, does the sliding fee scale, if there is a fee scale, potentially hurt by causing families who could pay it, but really aren't enthusiastic about the services, even if they need it, to just drop out so we don't get them and don't get them treated?
Director Schmidt.
Madam Chairman, Mr. Co-Chairman, my understanding is that the sliding fee scale is for people who are not in the priority population. And if I'm misunderstanding that, then my answer is going to be incorrect. Currently, the sliding fee scale applies to all of our families. So if there's a referral made and the child's not in care, then the community mental health or substance abuse center addresses that family based on the sliding fee scale. And I don't know if there's any adverse reaction to having to pay a cost, if that really does make or break the treatment. And that's on the pre-removal side. On the post-removal side, it's court ordered. So there's a different incentive to participate in treatment. But what this particular population that we're focusing on, we really want to engage and get them what we can so that children can stay safely at home and the whole family doesn't move into the court system.
More questions for Director Schmidt? Representative Sweeney.
Thank you, Madam Chairman. So, Director, my question, are there any private providers out there other than the counseling centers that the department works with at all?
Director Schmidt.
Madam Chairman, Representative Sweeney, yes, we work with a lot of private providers, but typically those private providers are Medicaid providers as well. And so the services that they provide are paid for by Medicaid, not by the Department of Family Services.
A follow-up, Madam Chairman.
Representative Sweeney.
Thank you, Madam Chairman. So my concern, part of my concern is in the bill, which I believe we need, but I don't want to throw out our private providers that aren't necessarily connected with a counseling center. And in your opinion, having looked at this bill, are we in any way, shape, or form ruling private providers out in this particular case, being they're signed up for Medicaid?
Director.
Madam Chairman, Representative Sweeney, I think maybe the Department of Health may have more comment on this, on what this particular legislation will do to their private provider system. But what I can tell you from a Department of Family Services standpoint is that we are not funded to really provide many services to families before they come into care. We hold our money really close to our vest for those families and children who are court ordered into our care, because we have to ration it somehow. What we would like to do then is utilize the leverage of the behavioral health contracts through the Department of Health to get those families, before they come into care, the services that they need. Now, if they have a private provider source, like maybe they're Medicaid eligible or they have insurance, we're certainly going to push that family to utilize those means first before we step in with any of our funds. But once the family's in our custody, then Medicaid eligibility for the children come into play, and we heavily use Medicaid providers for those services.
Thanks for that clarity. Thank you, Madam Chairman.
Representative Clem.
Yeah, thank you, Madam Chairman. Director, isn't it true that when a child is in the legal and physical custody of DFS in placement at a facility, that parents are oftentimes required to pay child support?
Madam Chairman?
Let me just add, so Representative Clem, can you clarify? I'm not quite sure. I'll let Director Schmidt answer it, but I don't, can you clarify for me how that fits into the issue of this bill, just so I know where I'm at?
Well, yeah, Madam Chair, we're talking a couple different things. Obviously, one, there's been discussion about a sliding fee scale. We're talking about those cases that they're not in the court system as of yet. Okay, that's one issue. The other is then when you do have those who are in the court system, and it's just to confirm or address that it's not as though parents are paying nothing when their child is then in the custody of the state. And that's really the point of the question, just to confirm or not confirm whether or not when that happens that parents are then required by law to pay child support.
Director Schmidt?
Madam Chairman, Representative Clem, yes, if the judge orders that child support applies in the case, then the case gets referred to the Child Support Services, and then they file the appropriate child support paperwork and go through the legal process that way, which is also done by the Department of Family Services through contractors, but two very separate legal processes. The custody process is through juvenile court statutes. The child support is a whole different set of statutes with their own rules. So the amount will differ, the qualifications differ. It's almost like we then say, okay, in a regular divorce situation where child support is ordered, the families who have had their children placed will go through that same process separate and apart from the juvenile court case. And I hope I didn't muddy the waters there, because this really starts to get kind of complicated.
Okay, right. And let's try to stick sort of to the prioritization issue and the various amendments. Okay, any more questions for Director Schmidt?
Yeah, I had a follow-up, Madam Chairman.
Representative Clem.
Yeah, and Cora, or Director Schmidt, excuse me, just going back to the whole issue with co-occurring disorders. I'm just reading here from drugfree.org. It says when a child gets diagnosed with a mental health disorder, in addition to alcohol or drug use dependence, he or she has a co-occurring disorder, also known as a dual diagnosis. When a child has co-occurring disorders, they should be treated for each of the diagnoses. Treating alcohol or drug abuse and dependence addiction alone does not help the underlying mental disorders. And similarly, treating the depressive disorder alone will not treat the addiction. And so I'm just wanting to make sure, and perhaps, and I just want your say so, maybe we don't need that language at all in the bill. I just want to make sure if we're prioritizing certain populations, that those who do have dual diagnosis are not going to get overlooked, in that the mental health side of things gets treated, but perhaps there isn't funding there, or something where the substance use disorder would not be addressed, at least not be addressed adequately. Your thoughts?
Director?
Madam Chairman, Representative Clem, my understanding of the bill, and the Department of Health can get mad at me later, but my understanding of the bill is this is about identifying a particular person and who pays for those services. So when a person then engages in treatment, there's going to be an assessment done. So for example, our families, if we refer to a community mental health and substance abuse center, the first thing they're going to do is assess. But because they're referred by DFS, they're going to fall under the priority population. Then that assessment or that treatment evaluation will then determine what services do they need. So if the determination is that through the evaluation, and of course we're relying on the expertise of the provider, of the treatment provider, then they will make the determination of which service, which therapy is the most appropriate for that person based on their evaluation. So that is how I understand this to work, and that's my understanding of how the system has traditionally worked. And so I'm not sure where the co-occurring fits in. I would assume that if somebody comes in with a dual addiction and mental health issue, that the evaluation will pick that up and then treatment will be prescribed accordingly.
All right, thank you.
Any more questions for Director Schmidt? Okay, then we will go back to our public comment. Thank you, Director, for coming in. Lindsay Simonio, I think I'm not ever, as long as I've talked to you, I'm not sure I've got your name right. I always want to put the accent on the neo, but I believe it's not there, is it?
Thank you, Madam Chairwoman. No, it is Lindsay Simino. That is not your fault. It really is mine. I'm the one that married the man with the name, but thank you for that correction.
It's no fault, I'm sure. Okay, Lindsay, just introduce yourself for a general record and then let us know what you've got to say.
Absolutely. My name is Lindsay Simino, and I represent the Wyoming Counseling Association. I am here today just to really inform the committee and the chairman that the Wyoming Counseling Association, though we may not have been as actively involved as WAMSAC, we have been watching this process, keeping tabs on this process. We have the majority of our membership includes both providers that work within the community mental health system, but also those private providers without the state. As was previously mentioned, as far as private providers being ruled out, we do not believe that the language of this bill does that. We believe that what the language of this bill does is prioritize the community mental health centers that have those contracts with the Department of Health, but that ultimately that does not limit the client's right to choose a provider. As previously stated, we do believe that those with private pay options as far as insurance or Medicaid will be able to still choose those private providers. Private providers within the state of Wyoming are known for doing some type of sliding fee scale or some type of self-pay scale as needed. Not all private providers, but many do pro bono work. And so we do not see this limiting the private providers' ability to practice within the state, but very much prioritizing those state dollars as they need. We really defer to WAMSAC's position on this bill since it impacts them and their centers the most, and since they most or best understand how their centers work and how these priority populations are going to impact those centers. And so I'm really here just for any questions the board might have as far as concerns for private providers or how we see this impacting both the community mental health and the private provider system.
Great, Ms. Simoneau, thank you. Any questions for Ms. Simoneau? Representative Sweeney.
Thank you, Madam Chairman. Thank you, Lindsay, for that information. So I guess my question would be on the private provider portion. My concern is if the person's not able to private pay, doesn't have insurance, and it appears one of my concerns is that they won't be able to seek help because they don't qualify for anything the way we have it. And I'm concerned about, some of your members that aren't part of WAMSAC membership, how that would work or appear. As a for instance, if they're well, I'll leave it at that. But do you have a comment on how your membership in those particular cases where they don't have private pay, could they slip through the cracks?
Ms. Simoneau.
Madam Chairwoman, Representative Sweeney, as you know of this committee, we have been discussing this for many years, and there are holes within our mental health system. There's not going to be a perfect way to fix all of the cracks. As I have discussed with Andy Somerville with WAMSAC, that part of this bill being successful will be increasing and formulating very much a greater state network between the community mental health centers and those private pay providers in order to make sure that we can help funnel those priority populations to the community mental health centers that do not have those payment options, but also vice versa, that they are able to funnel those people who may not meet those priority populations, but do have those private pay options to the private providers and increase that communication. It is not a secret that mental health is siloed within the state when it comes to different services. And so with this bill, it would need to be a priority to make sure that those silos are taken down. And WAMSAC and the Wyoming Counseling Association is eager to do that.
What questions for Ms. Simoneau? Okay, great. Thanks very much.
Thank you, Madam Chairwoman.
And I see Ms. Somerville.
Hello, Madam Chairwoman.
Good morning, Ms. Somerville.
Good morning. Andy Somerville with representing WAMSAC. And I'm here to answer any general questions on the bill. And then I thought I'd just provide a few comments on the amendments, Madam Chairwoman, unless you'd like to go over the memo that I sent in November again.
I have here, hang on, I'm trying not to lose all my pages. Okay, so committee, we did get, sorry, I'm trying to manage like 4 pages on my one screen. The committee should have received a memo from Ms. Somerville. I see revised memo December 1. Is that the one you're talking about?
It is. Yes, Madam Chairwoman.
Okay. I'm of 2 minds, frankly. I don't want to have you have to come in and out for every amendment. Committee, I think what we'll try to do is have Ms. Somerville go down. Actually, if we can do it in, this will kind of mess you up, Andy, maybe, but if we can go through the amendments as the amendments so that we can write your notes, write your comments on that page rather than in the bill, I think that'll, because Chairman Scott and I have decided we're gonna, when we go through the bill, we'll go through the prepared amendments rather than page by page, because some amendments come in on more than 1 page. So if you could go starting with, just start with the first one, and if you have nothing to say, say so, or if you do, and we'll just mark it on our amendments. I think that'll be the easiest way to do it. At least it'll be the easiest way for me. And seeing as I'm the chairman, I guess that's how it'll go. Go ahead, Ms. Somerville.
Thank you, Madam Chairwoman. I'd be happy to do that. And in that revised memo, just for the committee's information, I did lay out comments based on that order. They start with the Scott Amendment 1 and go all the way through. So
very good.
You should have that for your reference. So we'll start with Scott Amendment number 1. We support this amendment to put the 10% contribution back in. Scott Amendment number 2, we generally support this amendment with, but recommend a clarification on it. So after the word funds in that amendment, we would recommend inserting including.
What line are you on, Andy?
Well, let's see, on the amendment, it is line 11.
Okay.
So a comma after use and then put include.
Madam Chairman,
hang on, Representative Sweeney.
In her memo, could what pages I've tracked in Senator Scott's amendments, but I didn't title them number 1, number 2. I just marked everything. So if
Representative Sweeney, you are way ahead of us and marked them into your bill already. Very clever of you. I just printed out the pages.
But so is she now on page 6? On according to her, I'm trying to track her memo. Is
okay,
that
so we should
she's
probably, yeah. And Andy, I'm looking at I have kind of your memo from December 1 up, but I'm looking at the amendments. So Chairman Scott's proposed amendment 2 says page 17, lines 19 through 23, delete, and page 18, delete and insert. Is that the one you're on?
Yes, Madam Chairwoman.
Okay, so let's
okay.
Hang on, I'm gonna try to, and actually, Andy, I don't actually see that addressed in your memo.
Madam Chairman.
Representative Barlow.
Madam Chairman, the last page of Ms. Somerville's document has the amendments that she's speaking about. It's not the first couple pages.
Ah. Okay. Let's work off the last page of that. Good. Okay, Andy, we're on the last page of your memo. Everything is yellow.
Thank you, Madam Chairwoman. I apologize for any confusion. So working off of Scott Amendment number 2, which would be pages 17 and 18. In his amendment text, we would recommend, so on the actual amendment itself, it's line 11, not in the bill. We would recommend putting a comma after use and inserting the word including. So it would change the sentence to say, behavioral health centers, mental health centers, and substance abuse centers may use, including funds raised through service charges and fundraising for the delivery of services, etc. We wanted to try to clarify a little bit that the behavioral health centers could use funds that they may raise independently to help support expanded or additional services to the priority populations as part of their fundraising match, instead of just specific to non-priority populations. That's mainly a concern for the smaller centers, depending on their population mix and how much state dollars they're getting, that they wanted to be sure that they could use those other fundraising sources as part of their match.
Okay, Andy, just looking at this and committee, I realize this is going to be a little confusing because we're not working the amendments into the bill just yet. I'm just trying to mark up these comments, but it does seem to me, Andy, that we would actually want to say may use funds, including those raised, not just including. Am I?
Madam Chairwoman, you are correct.
Okay.
I apologize for misspeaking.
Okay, that's just very good. All right, go ahead.
Okay. So that's all the comments that we have for amendment number 2. Scott, amendment number 3, which in the bill is page 7, line 7. We understand the intent of this amendment may be to make sure that the smaller centers are not disqualified from being community mental health or the new definition of behavioral health centers. We don't know that it's completely necessary. We've had a longstanding policy with DOH, or I should say it's a DOH policy. They recognize the differences in the services that community mental health centers provide based on their location, their region, the community needs, state needs, etc. And so we haven't had that issue. We feel that having that national accreditation, which all of our community mental health centers really is the tie that binds, I guess, in terms of qualifying them as a community mental health center. So we don't feel very strongly one way or the other, but we just weren't sure it was completely necessary.
Okay.
Scott, amendments number 5 and number 6, and I'll speak to these together because they kind of deal with similar issues.
Madam Chairman.
Representative Sweeney.
Thank you, Madam Chairman. Could I go back to the previous one on page 7? So your suggestion, if we don't accept the Scott amendment, then that leaves it solely in the bailiwick of our community mental health centers. Is that what I understood? Versus a smaller, I know we've got a couple of smaller providers here in town for alcohol. So I'm just trying to understand.
Ms. Somerville.
Madam Chairwoman, Representative Sweeney, no, that was not our intent. Our intent was to leave the definition for any expansion that's needed to the Department of Health rulemaking process. The way that the community mental health centers obtain their contracts is through an open RFP process. And so we welcome anybody that wants to go through the possibility of standing up a center with those services and receiving that national accreditation. Our point was just that we didn't necessarily think that having that in statute was necessary.
Okay. Thank you.
Okay. Go ahead, Andy.
Okay, so Scott amendments number 5 and 6. So this is page 15 in the bill, and then a little bit on page 16. So if we understand the intent of this amendment correctly, it is really to direct that funding for the services, funding under the subsidy model in this bill would be directed towards providing those services that are necessary for priority populations. So the subsidy would support the infrastructures necessary for the priority populations. We understand that intent, But the question becomes, in terms of the language that's used, so it says in the amendment that would go on page 16, behavioral health centers may use the facilities, supplies, and personnel funded under paragraph X of this subsection to provide services to non-priority populations, provided services to priority populations are not materially diminished. In current contracting terms, the state doesn't pay or fund community mental health centers infrastructure or supplies or specific personnel. The contracts are set up to fund direct services. So they pay for client services essentially. And so the question becomes, is that a good model or way to form that in the legislation, considering that the funding hasn't been used? But of course, the question comes after, we haven't gotten to the part that would come after this bill, and that is, what contracting model would the state use? All of those questions would be answered subsequently. So.
Co-Chairman Scott.
Madam Chairman, if she's referring to my Fourth Amendment.
We're on the fifth one. They didn't have any comment about the fourth one.
Okay, then I'm confused as to where she is. Because the one on I thought she was referring to the one on page 15, line 22, no?
Ms. Somerville?
Madam Chairwoman, Senator Scott, I actually was referring to both amendments 4 and 5 as they're dealing with similar subject matter. So specific to amendment number 4, that would
that's not on your memo, Ms. Somerville.
Page 15.
I'm confused again. Okay.
Okay. So for Scott amendment number 4, page 15, it says that it would insert that costs would be incurred in providing necessary services to priority populations. And that has to deal with the subsidy. And then the following amendment, which I guess is number 5, stipulates that behavioral health centers can use the facilities and et cetera that were funded under this paragraph for priority populations to provide services to non-priority populations. And so I grouped those together, and maybe I shouldn't have. Understanding the general direction was to try to put some framework on how the subsidy might be determined and what the subsidy would pay in terms of operating costs. But the comments for number 5 on page 16, that additional language is just, we're not sure that referring to facilities and supplies and personnel is a good idea. Just because the state doesn't use that model right now for their community mental health center contracts.
Chairman Scott, did you have a follow-on then?
Chairman, I misunderstood what you was talking about.
Okay, although Co-Chairman Scott, is this one where are you going to have some amending language for 4 and 5, or?
Madam Chairman, the number 4 one, I want to revert to the language I sent to the LSO because this one could cause trouble.
Okay, so we'll committee will come to that when we work the amendments. Okay, Andy, did you have other comments on the subsequent amendments?
Thank you, Madam Chairman. And I would clarify, I apologize, on my memo, I labeled those 2 amendments, number 5 and number 6 for Senator Scott, but they were actually 4 and 5. So I apologize for the confusion. Okay. On Wilson amendment number 1, which deals with various pages in the bill, WAMSAC supports this amendment to help address that critical population of clients who may be seriously mental ill and kind of always on the brink of ending up in a crisis situation or Title 25 if they don't receive consistent care. So we support that amendment. On Wilson amendment number 2, which would be page 3, line 17 of the bill, the question that we had is if it's the intent of this amendment to prohibit the behavioral health center from charging fees, it would be maybe necessary to change the language on the subsequent page to say that the state shall pay for the gatekeeping costs. right now, the current model, as we know, gatekeeping is a little different in every county. Currently, several of our centers have what I would call local support financial agreements from either a hospital or their county commission to help offset some of those gatekeeping costs. As I read this amendment, it would preclude them from having that fee arrangement. So we would want to ensure the Department of Health was going to pick up some of those gatekeeping costs and fund that service if they were to be precluded from seeking support elsewhere.
So, Ms. Somerville on that, and I might have to ask Mr. Brody to help me here because I don't have it marked. My understanding of this amendment was that in one of the repealers, and I don't know which one it was right at the moment, in one of the repealers, there was actually a prohibition against charging fees. And the concern was just that by carrying out the repealer, we lost the prohibition on funds, or on fees. So we weren't trying to do anything different than what we're doing now. It's just that we didn't want to lose the prohibition. Mr. Brody, which repealer was that?
Madam Chairman, John Brody, LSO. So the bill repeals 35-1-624. And if you look at 35-1-624A5, the last sentence in that provision contains this prohibition that is the Wilson Amendment. So what really the effect of the amendment would be is to just maintain how statute currently operates. Perhaps the Department of Health can speak more to how the actual funding may flow, but thank you, Madam Chairman.
Okay, so let's flesh that out a little bit further when we get to the amendment, just so as to not have things be too confused. But Ms. Somerville, I'm sure you will be perfectly happy to stick around until we're done.
Madam Chairwoman, I will be with you guys till the bitter end today.
Bitter end.
And I think just to be clear before that discussion, the community mental health centers never charge a client gatekeeping fee services. That's not a practice. So,
well, and I think that yeah, well, we'll talk about that when we get there. Okay, is there? Let's see. Keep going.
Yes. On Wilson Amendment number 3, we don't have any issues with this amendment. To change the language on page 3, line 10, from prioritize to give preference to.
Okay.
And then on the WISA or the Roscoe Amendment, we just wanted to say we recognize that this population is very important to serve in terms of trying to keep children and families, maintaining services at an earlier junction as to hopefully prevent their entrance into the DFS system. It is easy to single out a lot of populations that aren't included in this bill, but we just wanted to comment that we do recognize that's an important population, and especially with children, the earlier the services, the better. And with that, I would stand for any questions.
Okay, questions for Ms. Somerville? Representative Barlow.
Thank you, Madam Chairman. So for that last comment about those services for those youth, do you have any estimate of what percentage of statewide percentage would fall into that category? And the reason I'm one, call in that category, and 2, whether you agree with the assertion by Director Schmidt to remove the federal poverty level criteria. Thank you.
Ms. Somerville.
Madam Chairwoman, Representative Barlow, unfortunately, I do not have an estimate. That is something I tried to dig up yesterday, but there unfortunately are limitations on data gathering in terms of poverty level, and exactly trying to sort out referral sources would be a pretty big data dig for that particular population. So sorry that I can't answer that. On removing the federal poverty level, that really is a policy question for the committee. We are always going to advocate for trying to provide necessary mental health and substance abuse services to the level that they're needed, but we realize the constraints that the state has. And so we'll work with whatever guidelines that you set. I'm sure that's not the answer that you guys were looking for, but if we had our dream, it would be, no, there wouldn't be a limit, but we might not get our dream.
I think the former mayor is coming out. Representative Barlow, did you have a follow-up? No. Okay. All right. Any more questions for Ms. Somerville? Okay, thank you. Katie, are there any more? Oh, I see Ms. Foland is there. Ms. Foland, welcome back. Oh, you're muted.
There. Thank you, Madam Chair.
Okay.
Members of the committee. Cheryl Foland, independent private practice provider in Rawlins, Wyoming, and also legislative advocate for the Wyoming Association of Addiction Professionals. For the most part, I won't reiterate each and every comment that we've had in the past. Our associations do, the association and myself personally, do have significant concerns about basically setting up a monopoly for the behavioral health centers. As far as the amendments, we don't have any major heartburn other than on the concerns as identified in proposed amendment, Wilson proposed amendment number 2, repealing 3516-24A5. We agree that some type of language needs to be documented as to charging fees or not charging fees for gatekeeping services. On Wilson number 3 amendment, we're good with the language on give preference to. On Scott proposed amendment 1, no real heartburn there. Scott proposed amendment number 2, identifying page 18's line 5 through 13. We agree with the co-chair Wilson's identification in the language of including those. The wording was rather awkward for what the intent is. One of the challenges I will bring to the table that was identified by Ms. Semino is that many private providers do in fact have some wiggle room as to providing services for those who are uninsured, underinsured, and we're not held to the same standards as the behavioral health centers, but some of the language could be applied to those of us that are providing for pro bono services if we are receiving state funds from the Department of Health. So just kind of our concern was just how that the wording was going to look. We always have these things called unintended consequences. In my very novice experience in working with the legislatures over the past couple of years. So just some extra thoughts there. As to Scott amendment number 3, I think one of our concerns is if in fact the behavioral health centers are going to be subsidized, my colleagues and I certainly would like great transparency from the behavioral health centers on how the subsidies are used, which also goes to Scott amendment number 5. We're good with number 4, amendment number 4. And number 5, obviously anyone receiving subsidies should not have a problem with providing open books, I guess, as to how their operating costs look like and what the taxpayers are subsidizing, especially myself, because this is, I'm subsidizing my competition. And that subsidy, I believe, needs to be identified on how that money is going to be used. And following, and I'm sure the Department of Health will have a nice list of what that's supposed to look like. Whether it needs to be in statute or not, I think it needs to have some open communication. But just the fact that anytime there's a subsidy, I think we as providers and taxpayers also need to know, where is our money going and what does that look like? So based on the amendments, I stand for any questions.
Questions for Ms. Foland? Representative Sweeney.
Thank you, Madam Chairman. Ms. Foland, do you have any recommended clarifying amendments that your organization has suggested or put forth?
Ms. Foland.
Madam Co-Chair, Representative Sweeney, at the moment, we are in the process of putting together those. I have also received some information from Hollis Heckman, who I don't believe is on today, and the Wyoming Psychological Association. So we're combining some of our recommended language that we would happily produce forthwith.
Okay.
So that's obviously something that can be brought to committee during session as we go forward with this. More questions for Ms. Foland? So I do have a question. When the Department of Health puts out its RFPs for the contracts, do your members bid on those or put in proposals?
Madam Chair, some of the larger centers who are not WAMSAC members do in fact put out bids they do respond to those RFPs if they are able to provide those services.
And so are some of them receiving the state funds? Some of your members, are they receiving state funds then, having received award under those RFPs?
Madam Chair, yes, they are.
Okay. Representative Sweeney.
Thank you, Madam Chairman. One of the concerns I've had with this is private providers being bounced out for one reason or another. They're not able to contract, provide the services, which is one thing. But you being in Rawlins, dealing with, I'm assuming you deal with some of the prisoners that have been released out of the penitentiary for counseling. Do you see this inhibiting any of that work? Because I'm not sure they're mentioned as a priority population. They should be, but I'm not sure if that's the total intent here. You have a comment on that?
Ms. Foland.
Madam Co-Chair, Representative Sweeney. Yes, many of our members across the state and private practitioners do in fact work with, especially here in Rawlins, we do work with people who are on probation, on parole. I can tell you that many of us end up doing pro bono services because we cannot or do not contract with the Department of Health or the Department of Corrections to provide services. one of the challenges we have is by statute to receive state funding, all certified providers have to go through a extensive process with the Department of Health, creating policies and procedures, addressing everything in statute, providing letters of references to become certified to obtain those DOC funds or the Department of Health funds. So many of us, because of the administrative efforts, we do not become certified to obtain those state funds. So we end up writing off quite a bit. We do a lot of pro bono work for that population.
Yeah, thank you.
Representative Stiver, I'll call on you in a minute. I was just going to say, Representative Sweeney, the state level justice involved is the very first category of priority population. And that's identified on the bottom of page 10. Persons who within the previous 6 months have been released or paroled from an institution, released or discharged from a Title VII institution, and who require continuing treatment. So they are there. Representative Stiver.
Yes, Madam Chairman, thank you. I'm just wondering how many members she represents that are private providers.
Ms. Boland.
There are currently 35 CAP providers, and I do have those statistics. Let me get to my, here we go. So there are currently 2,214 active credentialed providers identified by the Wyoming Mental Health Licensing Board. Of those 2,214, 1,706 are practicing in Wyoming. 45 are CAPS, Certified Addictions Providers. 15 CAPAs, Addiction Professional Assistant or Associate, I'm sorry. 101 licensed addictions therapists. Our organization primarily is focused on the addictions providers, but we do have, I believe it's close to 100 that have various licenses that include licensed professional counselors, licensed mental or marriage and family therapists, and licensed clinical social workers.
Representative Stiver, did you have a follow-up?
Yes, but how many do you represent? That's
We have
the number. How many do you represent in your association?
Ms. Boland, I'm sorry, we didn't hear you.
Madam Chair, Representative Stiver, we represent approximately 100.
Okay.
Thank you.
More questions for Ms. Boland? Okay, thanks very much. All right, Katie, is there anyone else remaining in the waiting room that showed up late?
Madam Chairman, that is it for public comment unless the Department of Health has additional information.
Department of Health, is there anything that you want to circle back on?
Madam Chair, this is Matt Petrie. No, there is not. Thank you.
Okay. In that case, public testimony is closed. We do invite the usual suspects to hang around because, as you know, sometimes it happens that we ask a question while we're drafting an amendment. But so my intention is to go through the amendments in the order that they.
This is Matt Petrie. No, there is not. Thank you.
Okay. Okay. I think somebody might have had their YouTube running in the background. So we're going to go through the amendments in the order that they were listed online. When we get to the end, if there are other ones that people had thought of while we were working, we'll take them then. So rather than go through page by page, as I said, because some of the amendments cover multiple pages, I'm just going to go the amendment specifically. So Chairman Scott, are you able to call in?
Madam Chairman, yes, I'm on. I've just turned my video portion off because of the bandwidth problems up here.
Okay.
And I would ask your indulgence. I've been kicked off this thing twice already this morning. I had to come back. I don't know whether it's a computer problem here or whether it's the bandwidth problem, but
okay. And
we
actually,
hope it won't happen again.
before I ask you to present, I realize I have forgot to ask for a motion on the bill. Is there a motion on the bill? I see.
Madam Chairman.
Move the bill.
Moved by Barlow, seconded by Schuler. Okay, and any discussion? So we'll basically go straight to the amendments because we've been discussing it at length. Co-Chairman Scott, please tell us your first amendment.
Madam Chairman, the first amendment is on page 20, line 9, deleting the repealer of 35-1-622B. That was discussed by Ms. Hurrell for WAMSAC, both at our first meeting and a few minutes ago. What it does is removes the repealer of the current matching requirement, which is a 10% match. I think they express it by you can only spend up to 90%, but it basically requires a 10% match. In addition to what she said on behalf of WAMSAC, I would say that we had quite a debate on this issue in the Senate a number of years ago. I forget whether it was when this requirement was introduced or somebody tried to remove it, but I can remember very much the late Senator Schiffer saying that this was very important in terms of having the centers create a base of local public support. And I very much agree with that. So that's why, and Madam Chairman, did I move the amendment?
Well,
If
I don't
not,
know,
I
but
do
go
so.
ahead and move it. Is there a
Okay.
second? Do I see a second? Some people have turned off their pictures. Well, I'll second it. Okay. Any further, Senator Scott, did you want to say anything more about that?
No, Madam Chairman, I think that covers it. I think this is an important feature that we need in the bill.
Representative Barlow.
Madam Chairman, and I apologize. I haven't worked this in well enough. But does the 10% then apply to the services that the state is assumably going to pay 100% of? So my question is, this applies to generally now all services, but if we're going to have a priority population, my assumption is we're going to pay 100%. So is this somehow set that priority population aside and only apply to the non-priority folks that would be under contract with or might have services from the same contracted provider? Thank you, Madam Chairman.
Madam Chairman.
Chairman Scott.
What this does, if it's there, is it applies to requiring a 10% match for just right across the board, that they have to raise 10% local funds in order to get the state funds. But the subsequent amendment clarifies that it doesn't have to be as specific to the state priority populations, and that they can use everything they raise on the non-priority populations. It does say you've got to have the support for the center, up to 10% of what you're getting from the state. But it does not say that you've got to use that on the state priority populations. Does that clarify?
So I'm just going to read that line from the statute, 35-1-622, paragraph B, and I'll just read the pertinent part. Funds contracted for under this act shall not exceed 90% of the total non-federal expenditures for human services programs by any community board or public agency. So in other words, whatever your expenditure is from that board or agency, you have to have 10% that isn't this state money. That's how I read that line. Did you have a follow-up, Representative Barlow?
Madam Chairman, I think therein lies, I think that conflicts with what the bill's intent is, to have 100% of the priority population. I mean, I thought it was, my understanding was 100% of the priority population covered. 10%, I understand, would be applicable toward the non-priority population. The language you just read, I'm not getting it pulled up fast enough, talks about the contract. So if the contract is for priority populations, then I don't know that adding the Second Amendment's language cleans that up or removes that. I think that they're still going to be required to have 10% to apply toward the contract.
So Representative Barlow, the way I take this, and we may want to have Mr. Brody or somebody weigh in, my assumption of the existing statute and what we're doing with this bill is we're actually going the other direction. We are saying we are contracting with you for X dollars. You shall, for those X dollars, you serve the priority populations. What you do in the rest of your life is up to you. They could actually serve more priority populations from other money, but they're getting whatever it is, $2 million or something. So I think the idea then is that, let's say they get $2 million, that they should be having in some way a budget of at least $2.2 million to do whatever. And what they do with the other $0.2 million is either priority or non-priority or whatever, but we're not directing that, because the only thing we're directing is what they do as a result of the contract. So actually, I don't know if Representative Larson, having really delved into this in detail, or Mr. Brody want to speak to that. Representative Larson.
Madam Chairman, I have some of the same sentiment that Representative Barlow has, as I confused, because we kind of make a shift in this bill on how the delivery of these state funds are given to the behavioral health centers now. As they exist today, there's this block grant of money that's available. We know what that is by a contracted amount, and then the behavioral health centers are required to make up 10% of that. We're making this shift, and we're saying we are going to focus the state's priority is, and the policy is to focus on these priority populations, which we're going to reimburse the behavioral health centers for those services. You don't have to come up with anything. We're going to, by contract, we're going to reimburse you for that. Now, in your other business, as you point out, Chairman Wilson, you're going to serve other individuals that may or may not fit into priority populations, but you're going to serve them. How they serve them is up to them. But this amendment says we are going to require that they come up with 10% of the contracted amount. The contracted amount is for these priority populations, which we are saying is going to be funded 100%. And so I'm a little bit of a loss on why we would, I'm not sure that I understand why we would want to reduce that funding. Or is the intent, say, that we fund the priority population? And I know that this is covered a little bit in another amendment, but if we leave the priority population alone and then say that they have to come up with 10% of the non-priority, that's not state funded. So why do we require them to come up with 10% of anything that we don't have any money involved in? And I just may not understand that, but I appreciate that requirement as it was 4 or 5 years ago, even up to today. But as we make that shift, I'm not understanding how and then I don't understand how we determine what that amount is. So,
Mr. Brody, did you have any legal information as far as the wording of the current statute? You're muted still.
Sorry, Madam Chair. John Brody, LSO. I guess just a thing to point out in the provision that would be brought back into statute if this amendment were to pass. It speaks to expenditures by community boards and public agencies. Those definitions are provided for in 35(1)(6)(13). My reading of those definitions is that it does not include what we are calling behavioral health centers. So there may be additional tweaks that would need to occur to this provision in order for it to apply to community mental health centers. But that was all I had to add.
Chairman Scott.
Mr. Chairman, I think maybe Mr. Brody's pointed out something we'll have to deal with during session. The reason for having this community match is twofold. First, it's important that these centers have a base of local community support that helps in terms of getting patients into them, that helps in keeping them connected with the community and being able to have good support to do the work that they have to do in cooperation with others in the community that are involved in this whole system. So I think it's valuable from that perspective. Second, the people of Wyoming, our constituents, have broad mental health needs that go beyond these priority populations. We're at a point where we are having to cut the state funding back just to make sure the priorities, which are really the Title 25 type people with that kind of mental illness, get properly treated. But the people that we represent still have a much broader spectrum need. And what I'm trying to do is provide some funding mechanisms so that there is some funding available for those non-priority populations. And having this fundraising requirement, local match requirement, is useful in terms of getting that done, which is why I think WAMSAC was in support of this amendment. So for both those reasons, I think we need to bring this back into the.
More discussion on the amendment. Representative Yin.
Thank you, Madam Chair. I am probably going to vote no on this amendment. I think my concern is similar to Representative Larson's and Representative Barlow's concern in that, this did make sense when it was a block grant, but now that we're saying we want to prioritize certain populations, but then also saying you also need to have 10% of your expenditures go outside of what we're contracting you with, it puts a requirement that I think is going to actually hurt our behavioral mental health centers and not help them. So I think ultimately I'm not going to put this requirement on them, and I will vote no on the amendment. Thank you, Madam Chairman.
Okay. More discussion. Okay, then we will vote on the amendment. If you are in favor of the amendment, please put your hand up in front of, so the amendment deletes the repealer, okay? If you're in favor, please put your hand up in front of your face so I can count you. 1, 2, 3, 4, 5, 6. Well, those opposed? 1, 2, 3, 4, 5, 6, 7. Okay, the amendment has failed. And thanks for putting up with me counting verbally like that. It's just because we have some extra folks on, I just need to make sure I'm not missing. Okay, Chairman Scott, second amendment.
Madam Chairman, lacking the First Amendment, the Second Amendment is not relevant.
Okay. Third Amendment.
Madam Chairman, The third amendment, page 7, line 7, department may designate centers contracts as behavioral health centers. Purpose of this article. The point of this amendment is to give the department a little more flexibility. There's a number of purposes for which you have to be a behavioral health center to participate in certain functions of this bill. There is an exemption in the bill already that the department can contract for people that don't have the full spectrum of services of behavioral health center. That takes care of the funding, and that takes care of the situation where we've got, I believe the testimony was 2 counties where the substance abuse are in different organizations. So you can fund them, but there's some other things, gatekeeping being amongst others, where the behavioral health centers get some special treatment. And I think it may well be, particularly in those 2 counties, you need to have some flexibility to say one of those 2 is a behavioral health center for the purposes of gatekeeping funding. And I think there's some more things. So it's entirely permissive with the department. The department may designate. It gives them some more options. And I think giving the department that flexibility, given this new definition we're introducing, restores the flexibility they've got now, keeps the flexibility they've got now. So I think that's worthwhile. That's why I move the amendment.
Is there a second for the amendment? Representative Clem, were you seconding? Or no? Is there a second for the amendment? Come on, guys, you all read these amendments, didn't you? Good. Representative Hallinan, thank you for seconding the amendment. Okay, any discussion for the amendment? Representative Clem.
Thank you, Madam Chairman. I don't know what to do with this amendment. I understand where this amendment is coming from, and I'm in full agreement actually with the intent of the amendment to give some more flexibility. I'm very, very concerned in this bill, not that we're prioritizing these special populations. I think that's entirely appropriate in how we spend the funds. What concerns me greatly is prioritizing different facilities. Now we're picking winners and losers. And that's the thing that really troubles me about this bill. I think there's other ways to fix the bill to limit that, and so I don't know where this amendment necessarily fits in there, because the department then could essentially label anybody it wants to a behavioral health center, and then it has to prioritize these behavioral health centers. I'm just not sure this is the right thing to do, and I think it really does muddy things up. But I'm in agreement with the fact that there needs to be some flexibility, and we need to not stick our nose in picking winners and losers. I think that's the real messy part of this bill. So I guess I'd like to hear more, to others as far as what they think about this. Thank you.
Representative Barlow.
Madam Chairman, so this is a definition, and I get a little, I think definitions need to be very clear. And so when I read what Senator Scott's amendment is, Madam Chairman, it seems to me that if you just struck the word comprehensive out of this definition, it would do exactly what he is proposing. Now, it's not quite that simple. You'd have to take a few more words out. The real operative part of this definition is actually the National Accredited Organization. That is the distinguishing factor. And we heard that testimony earlier from one of the participants. That is where there is a distinction between other providers and what we call CARF accredited. So I'm not near as concerned about the second half of it, the range of services, because I think what's going to differentiate folks is whether they're CARF accredited or not. That's going to be the lighting on. So I personally don't think the amendment is needed. And if we wanted to amend the language, I would say you could strike some language out of here, the comprehensive range of service the comprehensive range of and be done and not need the amendment. So you could just delete 4 words and not add that additional language, and I think have the same effect. Thank you, Madam Chairman.
More questions or more discussion on the amendment?
Madam Chairman.
Co-Chairman Scott.
Madam Chairman, I think the key in this amendment is the department may designate its flexibility for the department, and I think will prevent some problems if the definition we've put in proves.
Okay, you kind of cut out, Chairman Scott. Did you finish what you meant to say?
I can't tell what went through and what didn't, Madam Chairman. I got an unstable bandwidth notice in the middle of it.
You basically reiterated that it would provide flexibility for the department.
Yeah. Okay, Madam Chairman, that's the only plan.
Okay. Representative Larson. You're muted. You're muted, Representative Larson.
I thought I had unmuted. I apologize, Madam Chairman. And just for the committee's benefit, if they would look in their bill over to page 14. Well, actually 13, at the very bottom of 13, we're in what the Department of Health can do. And in B, the department shall, so it's mandatory. And then you come under 6, it says that if a behavioral health center cannot provide sufficient services, the department shall select the most appropriate service provider in order to achieve an effective and efficient delivery of mental illness, substance abuse disorders, human services, and programming. So our intent, I will just tell you, the intent was to leave a definition of what a behavioral health center is. And we really reduced that out of Title 25 from what it currently exists. And Representative Barlow is accurate. The most important thing is it's a nationally accredited, and then provides a comprehensive range that will be determined by the Department of Health. But if you're in a part of our state that does not have, that has a provider that doesn't have the range that the department would like to see, typically on page 14, they have the flexibility to change that. And we've done that purposely because we don't try to give direction through definition. So we did try to accommodate that.
Any more discussion? Representative Barlow.
Madam Chairman, maybe this is for Senator Scott, because with Representative Larson's explanation of what's done later in the bill, the way I read it, it was not require CARF accreditation because there is a shortage of that type of provider. Are you assuming with this amendment, Senator Scott, that these whoever would be allowed, or the flexibility would allow someone who, but they would still have to be CARF accredited? Because I think let's make sure we're on the same page with that as well. Thank you.
Co-Chairman Scott. You're still on mute, Co-Chairman Scott. Co-Chairman Scott, you're on mute. Can you? I'll see if I can unmute him.
Madam Chairman, yes, there still would be the CARF accreditation requirement. It's the exception is they may designate a center which contracts for substance abuse or mental health services, which do not provide a comprehensive range of services. So the exception here is flexibility for ones that don't provide the comprehensive range. And the testimony, we had those 2 counties where that's true. And it's intended to give the department flexibility for dealing with those circumstances. It's not intended to give flexibility on the CARF accreditation. And the bill already takes care of the issue, can they contract with them? It's the other things that this definition does that may be important for. And maybe we'll never use this. Maybe we'll find that we've got a glitch somewhere where if we don't have this, we'll have to come back and insert it with the further statute. We're just trying to get, I'm just trying to get the department enough flexibility so they can manage this new process without having some unforeseen glitch.
I think I might here need to actually call back. I don't actually, oh, Ms. Somerville is still here, or Ms. Simino perhaps. Just to clarify for us the issue of the accreditation. If we could understand from one of the two of you how restrictive the accreditation is, are we more likely to have accredited organizations that don't provide a range of services, or are we more likely to have a range of services or some services that aren't accredited? I guess I just need to have that clarified. Ms. Somerville or Ms. Simino, could you help us on that?
Madam Chairwoman, Andy Somerville with WAMSAC. Just so CARF accreditation is a very intensive process that has to be renewed every 3 years, I believe. Every center's CARF accreditation process is slightly different based on the services. So a center that has mental health and substance abuse services would look, their accreditation would look different than, say, one of our centers that just provides substance abuse services. So it is based on the services that they're providing. But one of the important criteria of CARF is that has to be comprehensive for that particular field. So if it's substance abuse services, they'll check on counseling and case management and follow up and, meds management and all of those things that are specific to those services. So essentially it's an individual plan for CARF accreditation per center.
And do you know offhand what percentage of our providers, I would hypothesize, well, I know I won't hypothesize. What percentage of our providers are accredited? I mean, how much of a limitation is this in the state?
Madam Chairwoman, to the best of my knowledge, I guess I shouldn't say all of the community mental health centers that are under contract right now, there's 18 of them are CARF accredited. That's a requirement from DOH. For private providers, I couldn't speak to that because it would be incredibly, CARF accreditation is expensive, it's intensive. It goes beyond just verifying you have services. It looks at quality of services, incidents that might have happened, follow up, all of those things. And so that process is incredibly long, and most private providers just don't go through that process. And I would ask Ms. Simino to speak to that specifically to the private provider side.
Ms. Simino?
Madam Chairwoman, as far as private providers, yes, Ms. Somerville is correct. For private providers, it is not cost beneficial in many cases for private providers to keep up that accreditation. Now, there are group practices that do consider that accreditation from time to time. But again, it comes down to weighing that cost benefit of, is it worth keeping the accreditation in order to get those DOH dollars? At the same time, that accreditation is that transparency that is being asked for when it comes to how do we spend those taxpayer dollars. So it does serve a purpose, but it is something that private providers, whether it's 1, 2, 3 in a small group, usually do not pursue.
So typically, because of either volume or low number of, because of either volume of patients or low number of providers, you're not likely to have the capacity to become accredited. Is that basically what you're saying? I mean, you could a sole provider who had a bequest from his Rockefeller uncle become accredited? I mean, it's.
Madam Chairwoman, yes. If a private provider had all of their ducks in a row and could conquer the accreditation and stay up on that accreditation every 3 years, that is something that they can pursue. However, many private practice practitioners are doing the job of the scheduler, the biller, and the provider all at the same time. It would be similar to me as a private provider holding multiple licenses in multiple different states. Would that increase my likelihood to see clients? Yes, but is that cost beneficial Is that highly expensive and extensive on my administrative workload? Absolutely. Which is why most of us just have that license in the state that we are practicing in. I hope that example helps. But yes,
I think that
for
was
most
helpful.
of us, it's not cost beneficial overall.
Okay, thank you. I think that was helpful. Okay, unless there are questions for Ms. Several, Ms. Semino on that, let's return to the discussion of the amendment. Representative Hallinan.
Thank you, Madam Chairman. I would ask Ms. Somerville, I think she said that 18 mental health centers are certified, but we have 23 counties. Do those other counties have a mental health center, and are they certified? Thank you, Madam Chairman.
Ms. Somerville.
Madam Co-Chair, Representative Hallinan. So we do have in a few locations in the state where one organization, I'll pick on the southeast corner of the state, serves multiple counties. And per contract right now, each county does have an office. So for example, in Southeast Wyoming, there's one county that has I would say the main branch of the community mental health center. And then there are 3 surrounding counties that have smaller offices to provide those services to those counties. So they are being served by a nationally accredited community mental health center. And that is true for every county in the state.
Thank you.
Very good. Okay, more discussion on the amendment. So again, remember the amendment is Senator Scott's Amendment 3, that the department may designate centers as behavioral health centers when they do not provide a comprehensive range of services. However, we are not deleting the requirement for nationally accredited in this amendment. So if you are in favor of this amendment, please raise your hand. 1, 2, 3. Those opposed, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. We seem to have lost a few people, but the math doesn't come out that way. Okay, that amendment fails. Okay, Scott, Amendment 4. Co-Chairman Scott, are you still with us?
Madam Chairman, yes. And Madam Chairman, the 4th Amendment, this is one, and I apologize to Mr. Brody, I didn't catch it on the first pass through and did on the second. The amendment that was been posted, I believe, it doesn't follow the original instructions, and I believe it would be destructive. The language I would propose instead is page 15, line 22, after costs, insert needed to provide services to priority populations. That we do need to specify what those costs are. And as I understand the concept in the bill, that, for instance, if you have a particular kind of therapist you need, and they're needed half time for the priority populations, but the only way you can get them is you can't find a half-time one, they're full-time or they're none. Then you have to pay for a full-time one. So that would be a cost that was needed to provide services to the priority populations, even though half of it would probably be used for other purposes because you only need half of the services demand. That's what I'm trying to get at. Just trying to clean the language up a little with this.
Okay, so just to clarify, and then I'll ask for a second, the typed amendment that came out is being changed, or that, so in other words, you're looking at page 15, line 22, but that's not the text that Senator Scott wants to amend in. And instead it would say, after costs, insert needed to provide services to priority populations.
Madam Chairman, that's correct.
Okay, is there a second? Senator Bouchard. Great, thank you for seconding, Senator Bouchard. Okay, is there more discussion? Okay, well then, and I admit that we may possibly need to clarify that language even a little bit more during session, just to make sure we understand what it is. But if there's no more discussion, all those in favor of the revised amendment for the language as we read, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and I'm 13. Any opposed? Somebody must have disappeared. There you go. Finally, Chairman Scott, you hit one out of the park. Good job. Okay, that one passed. All right, then the next amendment is Chairman Scott, Amendment 5. And do you want to explain that one?
Yes, Madam Chairman, I'll move the amendment and explain it. What I'm trying to do is make clear that the behavioral health centers may provide mental health or substance abuse centers to non-priority populations through any combination of services other than the state funding, and that they can use the, again, going back to the example I cited before, you have a whole person because it's the only way you get the service, and half their time is not taken up by the priority populations. Even though that person may be funded through the state, you can use that as to provide non-priority services, provided you don't diminish the services to the priority population. And then it's an authorization. When the means of the state allow, the department can seek through the budget process monies to deliver mental health and substance abuse to the non-priority populations, so that we don't have to have a special bill. And Madam Chairman, the reason for this is I have seen a number of people with pretty severe mental illnesses that would not reach the level that we set in priority. But it's still very debilitating. It may impoverish the individual, so they may need to have a public source of service. And I want to make it clear that we haven't given up on those people, even though the state right now can't afford it. I'd like to go back to having some mixture of funding for those people, frankly, but we can't afford it right now. But give the center as much flexibility as they can with the other funds they can raise, and where we're supporting them to keep them going, to be able to use some of those things that they can do without diminishing the services to the priority population. So I think this concept is very important in terms of this legislation. I would urge adoption of the amendment.
Is there a second? Seconded by Baldwin. Discussion on the amendment. Oh, Mr. Brody.
Madam Chairman, thank you. John Brody, LSO. I apologize for not recognizing this earlier. It's merely a housekeeping issue, but this idea or this term of non-priority populations really is the same as a defined term that we have in the bill called general access clients. So the committee may want to consider, just for the purposes of consistency, switching out non-priority for general access.
Chairman Scott.
Madam Chairman.
Mm-hmm.
Madam Chairman, I would suggest that if this passes, we give the LSO license to make that substitution with a defined term there. That helps it.
Senator Baldwin, is that all right with you? Was it you? Okay. All right, and that showed up. Mr. Brody, am I correct? 3 times in that paragraph?
Madam Chairman, I believe so, yes.
Okay. All right. Any discussion on this amendment? Senator Representative Clem.
Yeah, thank you, Madam Chairman. Thank you, Madam Chairman. My mouth is going faster than my brain, or vice versa. So the question is this: if we don't have this amendment in there, would it preclude these facilities from doing the same thing? I understand. I totally agree with the intent of the amendment, but I don't know if it's absolutely necessary. If it is necessary, then that concerns me even more, because it means we're really regulating to a high extent private organizations. I mean, these are what we're talking about here with these behavioral health centers. These are not under the purview of the state. These are just receiving state funds. They're private organizations. So I really hesitate, if this indeed is absolutely necessary, then we've really overregulated here. So is it necessary? Thank you, Madam Chairman.
Chairman Scott.
Madam Chairman, I would say it is highly useful for 2 reasons. One, when we do our finances recover and we can finance some of these people who are in the other populations who have severe mental illnesses but don't qualify as a priority population, I think we need to go back to doing it. And this would eliminate the need to do a separate statute. All we have to do is fund it in the budget process. So that part is useful. It's not necessary for this bill, but it's useful to preserve our ability to go back to what we have been doing that we can no longer afford. With this, we can go back to it when we can afford it. Second, it may be necessary, depending on how the bureaucracy reacts to the legislation we have passed. With this amendment, and you're a small center, you've hired a substance abuse therapist of some kind because you need them for the priority population, but you only need half of their services, but you had to hire a whole person. What does that person do with the rest of their time? The risk would be that the bureaucracy had said, well, since we funded you entirely for the priority populations, that's the only ones you can work on. You can't come over and assist in these others in the time that you don't have to use on the priority populations. You would think you wouldn't have to legislate that, but given the bureaucracy and the way it behaves sometimes, I think you do. So that it's a precaution to make sure that the intent of the bill is followed through, where we've provided funding in order to keep the doors open and keep the services available, so they're available to the priority populations, but they're not fully occupied with that.
More discussion on the amendment. I don't see any. All right, and then we'll vote on the amendment. If you're, all those in favor of the amendment, please raise your hand. Just keep it up so I can count easily. 1, 2, 3, 4, 5, 6. I think some people have departed. Those opposed. 1, 2, 3, 4. I'm gonna have to. I only added up to 11 people with my vote. So I mean, let me just start again. Okay, those in favor of the amendment, please raise your hand. 1, 2, 3, 4. Now I only had counted 5. Hang on. Keep them up. 1, 2, 3, 4, 5, 6. Okay, those opposed? Keep them up so I can. 1, 2, 3, 4, 5. Okay, I guess some people departed. All right, that amendment passed. 6 to 5. I'm not voting now unless I have to, because I'm busy writing and turning the pages. Okay, next amendment. Well, that one, the next one is mine, but this one looks extremely lengthy because it has all this delete this and insert that. The only reason for all that excess is because we decided it should be another paragraph. And so we have a new paragraph. Other than that, the only real content of the amendment is on lines 11 through 14 of the amendment. And where that fits in is on page 6. So if you look at the bottom of page 6, we had one of the categories, which was a priority category I think in tier 1. Adults with acute mental illness means persons who are subject to emergency detention, involuntary hospitalization, or directed outpatient commitment, or were basically recently released. And in our last committee meeting and in just offline conversations, we had a lot of concern with the idea that we're not going to help you unless you've gotten into trouble and harmed yourself or somebody else. There are a lot of people who, through good case management and medication and such like, can continue on in the community fine. And we didn't want to leave the situation such that you couldn't get any help unless you really went off the end. So I have inserted this paragraph to have another group called adults with severe mental illness. And I'll tell you, I looked on the SAMHSA website and various other sites. There is really no generally accepted, good for everybody definition of severe mental illness. So I really cribbed from something that the county attorneys were trying to do and didn't. But so as you see, it says adults with severe mental illness means persons who, based on diagnosis and history, have a substantial probability of being unable to meet their needs for food, shelter, and medical care if they do not receive regular mental health treatment or case management. Now, obviously, that doesn't include everybody in the state of Wyoming. There are some people that go to work perfectly fine and come home and pretty much lie in the bed the rest of the day, but then go back to work. I guess those people would not be in the group. But given our constraints, I just really wanted to pick up the people who would really be in trouble, but perhaps not harming someone else if they didn't get the case management or the treatment or the medication. And then that you'll see as we go down the amendment, this category is inserted in the priority list right where the severe mental illness category was. I mean, so in addition to that, it's just that we labeled them separately. You've got the one group that is really the Title 25, Title 7 type people, and then this other group who also has severe problems but haven't fallen in there. So that's all. That's what I'm trying to do here, and I will take a second. Seconded by Representative Stivar. Okay, are there any questions or discussion? Chairman Scott. Yeah, you're still muted, Chairman Scott.
Okay, I hope that did it.
There, now we hear you.
Madam Chairman, one of my concerns here is that as I read the original language, it might exclude people who we managed to have the gatekeeper divert before they got institutionalized. And I read your amendment as, amongst other things, curing that. Is that an accurate read of your amendment?
Mr. Co-Chair, I think that would, yes, if the person didn't actually hit the gatekeeper because they were picked up for some potential crime, but just visited them and came in and said, help me, then yes, these people would be helped here.
Okay.
More discussion. Okay, then all in favor of this amendment, please put up your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. I'll vote for my own amendment. 11. Any opposed? I see none. Okay, that amendment passes. All right, the next two amendments are actually LSO amendments, but they put them under my name. So the second amendment was, we discussed earlier the issue of having kind of inadvertently deleted, in addition to that one repealer, we inadvertently deleted the part forbidding them from charging fees for gatekeeping services. We did hear from Ms. Somerville that they don't charge for them anyway, and that's good, but presumably they're following statute in that where we don't let them charge. There was discussion, sorry, I'm trying to find the repealers on my bill. There was discussion that there might be confusion, and I can't remember who brought this up, that this might be interpreted as not being able to collect funding from the county or some such. Personally, I don't interpret the word fee in that way, so I'm okay with the bill, with the amendment as drafted, but I can hear on that. So that's this. Is there any second for this? Co-Chairman Scott. Okay, is there any discussion? I see no discussion. Okay, all in favor of this amendment, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Okay, I'm 12, so that leaves 2 people who didn't vote or aren't here. So that passes. The third amendment, again, this was an LSO one. On page 3, line 10, this is in the Title 25 component. The language, the inserted language maintains the gatekeeper concept, but says shall prioritize a behavioral health center and LSO. And Mr. Brody, if you want to flush this out, but LSO just felt that the give preference to was a little bit clearer. I would suppose not to confuse the different prioritization schemes that we have going on in this bill, one with patients and this. So we're just going to change the language to give preference to. Mr. Brody, do you want to add to that?
Madam Chairman, only in the sense that, yeah, by using the term prioritize, it tends to conflate the two ideas that are being put forward in this bill. So by putting give preference to, we avoid that potential issue.
Is there a second? For purposes of discussion, seconded by Representative Yin. Okay, is there any discussion of this? I see none. People must be thinking of lunch. Okay, then all in favor of this amendment, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Any opposed? I don't see any, although I didn't see Representative Barlow vote, but it's 11 to up. Representative Barlow, you're muted somehow. I don't see your mute button there. Nope, now you're muted again. Representative
Sorry,
Barlow.
Madam Chairman, I had some interconnect difficulty. I had to connect difficulty. Sorry, I was out for a bit. Thank you.
Okay. Okay, so that amendment passed. The final one is Representative Roscoe's amendment. We had some discussion with this with Director Schmidt before. Representative Roscoe, would you like to present it?
Thank you, Madam Chairman. Yes, this amendment goes on top of page 8 after B Romanet 16, and it's a separate paragraph. And let's see. It addresses a population, a priority population that that is in need, and it addresses them before they get to DFS or any state agency. And it gives an early chance for engagement with this population. And Mr. Berkland has already talked a little bit about it. I might repeat some of his things. Oh, and by the way, Madam Chairman, I would like to apologize for missing roll call this morning. I'm in the same situation as Coach Chairman Scott about tough reception here. But
That's all right. I
Wyoming
forgive,
Youth Service.
we forgive all of the people who have bad reception because it just reminds us of the need to expand our internet capability across the state for services of all kinds. Thank you for your prop for that project, Representative Roscoe. Go ahead.
Well, thank you, Madam Chairman. I hope they get it down to Big Sandy, Wyoming, where I am at the moment here. But so the Wyoming Youth Service Association, WASA, has crisis centers that have served between 1,400 and 1,600 people during 2016 and 2019, with an average stay of about 13 days. And also there's about 85% of the kids that are returned home without any involvement with any state agency or the juvenile justice system. And they're in out-of-home placements as well. The vast majority of these kids are voluntary placements. They have no state agency involvement. Most are brought in by their parents struggling with these kids' behavior. So once again, it's the ability to get in there early. So these crisis shelters are used as a cool down period. So they can do some case planning and they can deal with difficult struggles from both the child and the parents. These crisis centers also frequently coordinate with evaluation and treatment with the local community counseling centers. A majority of these children are not on Medicaid, and many of them have no insurance. Some of these families can afford to pay the community, their community counseling centers, but many may not. So what this does is it sets that limit of $200, 200% of the federal poverty. You know what I mean. I just lost my place here. The federal poverty level, anyway. So it is a category of families at high risk. So I would also like the chairman to, if Mr. Berkland would like to chip in on this, he is more knowledgeable than I am about this. So I think it's a needed category. Thank you, Mr. Chairman, Madam Chairman.
Is there a second for Representative Roscoe's amendment? Seconded by Chairman Scott. Okay, Mr. Berkland, if you'll just hold on, because I think between your prior explanation and Representative Roscoe's, I think we probably have the gist of it a little bit. But we'll certainly call upon you if people have questions. Representative Barlow.
Thank you, Madam Chairman. So my query is, and this is based on what I just heard Representative Roscoe testify to or explain to, is who is making the referrals if it's not DFS? Because this specifically speaks to referrals, and in the previous subsection that this is going below, the current B, it talks about referral from DFS. So my question is, and I don't know if Director Schmidt is on the phone and could weigh in on this too, but who would be making the referral that's referenced to in this? Thank you, Madam Chairman.
Representative Roscoe, do you want to answer that? Or are you going to call a friend?
Well, I think I would defer this. Thank you, Madam Chairman. I think I'll defer this to Director Schmidt. But I can say that the majority of these kids are usually brought in by their family with no referral, I think. Thank you, Madam Chairman.
So they're self-referred. Director Schmidt, are you still there?
Madam Chair, she is not, but I have requested her to rejoin if she can. Oh,
Okay,
she's on now.
Oh, okay. Director Schmidt, we just had a question about the proposed Roscoe amendment. Are these children who are referred by DFS, or are they self-referred often, or school, or do you have a sense? I appreciate that if they're not yours, you maybe don't know, but.
Madam Chairman, and I think Representative Barlow had asked the question. I was in cyberspace for a minute, but often the children that are placed in crisis stabilization services for the 13 days, as was noted, are parental placements. And so we probably will not have a whole lot of knowledge other than we pay for the service. But we don't get involved from a case management perspective. So no, we wouldn't necessarily know who those kids are and make the referrals unless we were contacted by the crisis shelter.
Okay, I was looking while I was writing. Did you have a follow-up, Representative Barlow?
Thank you, Madam Chairman. So I want to be clear. If the Department of Family Services is already paying for these services at crisis stabilization, and now we're saying we're also going to fund it through Department of Health as a priority population, I just want to be clear. I understood what Director Schmidt said, that they were already covering these costs, I would argue preemptively, before they even know what the costs are. Thank you, Madam Chairman.
And if I can just piggyback on that, Director Schmidt. So as I understand, actually, DFS is paying for the bed space, but not necessarily the counseling, which would be received elsewhere. Or just clarify that there, Director Schmidt.
Madam Chairman, Representative Barlow, it depends on the facility. Some of the facilities have the capacity to provide those services because they're attached to a larger organization. So they may utilize treatment services that are available through their milieu, so to speak. And then the payment for those services come from a variety of sources. For example, I know that in Casper, that they have staff that are part of the care management entity, so they can use those funds to pay for services provided to the children. I think what the intent of this legislation is, and I'll certainly defer to Representative Roscoe and Bruce, is it's really about when kids leave the crisis stabilization services. So it's a referral back into the home, but I could misunderstand. The original conversation, I misunderstood the amendment. I didn't understand it to be expanding the population. What I was understanding it was to put a threshold on the DFS population. This kind of just opens up the pool a little bit more.
So, and I'm going to call in Mr. Birkeland because I'm sure he is more knowledgeable, but I'm thinking that the population in this paragraph, when it says have been referred to, they could be self-referred, but they might just be children living at home who are acting out and family is concerned about them not going to school and various other activities, and they want to be able to refer themselves to a community behavioral health center. But Mr. Birkeland, would you want to flesh this out for us a little bit?
Madam Chairman, excuse me. Yes, I mean, that could be the case. In particular, we're thinking of the kids that are in the crisis shelter or other early intervention programs, and in a center where there isn't, as Director Schmidt said, some of the agencies have therapists available, and that does not affect these kids. It doesn't have anything to do with this. For the smaller centers that don't, they work, and a number of them work very closely with community counseling centers. So the referral could be coming from the counseling center. It could be coming from the parent. It could be coming from the school. The original intention was thinking in terms of particularly from the crisis shelter, but with more thought, there are those other sources of people that could be referring this population to the counseling center. And it might be while the kid's in the crisis shelter, or more frequently, as Director Schmidt said, it would be part of the treatment follow-up that's recommended from the case planning that's done while the child's in the crisis center.
So in my mind, committee, what this, and we can hear some further discussion, but this is, in some ways, this is a parallel to the amendment that I made with the severe mental illness, in that we're trying to provide services to people before they get into a judicial system or some similar situation. But here we have youth who, as we said, might be acting out, may have run away from home, may be failing in school and causing trouble at school or something like that. And we don't want the child, the previous paragraph, if you look at the bottom of page 7, is people who have been referred by DFS to prevent removal of the child from the home or to reunify them. Now we want to prevent them from ending up in the legal system at all. Okay, further discussion on this. Representative Yin.
Madam Chairman, I wonder if it's appropriate for me to make a motion to amend this amendment.
I believe it would be a fine time. Make your motion.
Madam Chairman, I'd like to move to amend this amendment and strike everything after judicial system. So we no longer have the income threshold as mentioned by Director Schmidt in her earlier testimony.
Is there a second? Seconded by Barlow. Okay, discussion?
Madam Chairman?
Representative Yin.
Yeah, I just want to, Madam Chairman, thank you. I just want to reiterate the reasoning for this is to help not only prevent the impact on the child's life once it interacts with the judicial system, but also to reiterate that this would also impact the state's costs once the child enters the judicial system. So everything that we can avoid to avoid entering a child in the judicial system is a cost savings in the long run. And as such, I think it makes sense to just remove the income threshold in this part.
More questions or more discussion on the amendment to the amendment? Senator Bouchard.
Yeah, I just have a question for that maybe that Ms. Schmidt could answer is how are we handling this now? I mean, don't we have, I mean, I kind of, as we keep moving on this bill, I keep seeing we're tying the hands. I mean, I get it, but that we just started out as a conversation that we're running out of money, but where do we go when priorities change? I mean, we're going to put all this in writing. We should appropriate and then let the executive branch execute. I mean, I just don't know where we're going here. So the question is, how do they handle this now? Is it on a case by case? Because you just don't want to open the floodgates and say, hey, here's money. But I mean, don't we already kind of do that? We have places where we can help children that need help, and then others that can be prioritized through the system we have now.
We can give Director Schmidt a stab at it, but I think maybe Mr. Petrie might be more suitable. But go ahead, Director Schmidt. Do you have an answer to this?
Madam Chairman, Senator Bouchard, no, I think I'll let the Department of Health answer that. Thank you.
Mr. Petrie, are you there? I see your rectangle.
Madam Chair, yes, I am. Thank you.
Did you hear the question?
I did, and I'll attempt to answer it. I may defer to Ben Kiefer, who is the manager of our mental health and substance abuse section here at the Department of Health. But particularly with juveniles, what we have is, I think, a system that is not as well developed, certainly, as for adults. And so when we have juveniles that need treatment, that are part of the system, what we typically have are instances where those juveniles need to be treated in out-of-state facilities. I might ask Director Schmidt to correct me if I'm wrong on this, but The volume of those juveniles, I wouldn't say is relatively high, but the acuity of their behaviors, I think, is, especially in those cases where we need to look for treatment in out-of-state facilities. But in terms of prioritization, I think that they certainly probably fall within the priorities that are set in the bill, the way that they're set out, A through, I believe it's F, and the top 4 priorities being in tier 1.
So, Mr. Petrie, are you saying that you think this paragraph that we don't need to specifically address children because they would fall, well, they don't fall into adults with severe mental illness, but that they might be indigent clients with high needs? Or I didn't quite understand what you meant.
Madam Chair, yes, I think that that's a fair statement, a fair conclusion, based upon what we have seen, what we have experienced, and that they would fall into potentially one of those 2 last priority populations, indigent clients with high needs, and or indigent general access clients, more likely indigent clients with high needs.
So in that case, we would only, as written, only be dealing with the people who are under 100% of the federal poverty level in those paragraphs. Okay, further discussion on this amendment.
Question on the amendment
Madam Chairman.
Hang on, I have a couple more. There's a couple more questions, Representative Clem. Thank you, Mr. Vice Chairman. Go, Chairman Scott.
Madam Chairman, speaking on and for the amendment, this is an amendment. I think if we had, I would be for it without reservation, but we don't, and I have a concern here. And I'm going to tell you, I think we ought to adopt the amendment in spite of the concern. This does broaden the bill, and we're trying to set some priorities so that we can keep our expenditures within the funds we've got. I'm concerned this may broaden the bill too much, but I think the better strategy is to put the amendment in at this time and then look for a way where maybe we can narrow it down or compromise it, maybe make this a second priority if we can afford it. Maybe we can use the existing language and not just confine it to the indigent. There's a number of ways you could perhaps compromise this that would enable us to keep with the priority setting mission. But some of these juveniles have very severe problems because, for instance, schizophrenia will manifest itself starting sometimes in the teen years, sometimes not starting till people are young adults, but they can very well start when they're still juveniles. We want to get at those people before they have to go to an institution. And this amendment, I think, achieves that. I think it may achieve some more things, but I would urge us to adopt the amendment, even though it may be too broad, and we may need to, during session, find some compromises that can get it more in line with our financial realities. But I think it's something we cannot ignore because these kids can be so severe.
Representative Roscoe, did I see your hand?
Thank you, Madam Chairman. I would like to agree with Co-Chairman Scott on what he said. I think it does expand it, this amendment to my amendment. And Yeah, I think we could correct it maybe at the next session if, or pass it. But I think we were getting a little bit away from the purpose of the bill, which is just to allow these people that are having trouble, may not go to a crisis center because they can't afford it. But they certainly could use some help with early detection of these some children or family problems. And so I'm hoping that we can stay with that as the main idea behind it. And then I would like to also see if Mr. Berkland has anything else to add.
Well, Mr.
Thank you, Madam
Berkland,
Chairman.
do you have anything else to add before we take a vote on the amendment to the amendment?
Madam Chairman, I'm not sure. No, I won't add anything. I will say that this does not pay for the crisis shelter services. It's just paying for those kids whose case plan and treatment planning, as pointed out, that individual and family therapy will be helpful for addressing their problems and helping keep them out of the system. And that's for those families that can't afford to pay for that on their own. And that's the point of it.
Okay, any more discussion on the amendment to the amendment? Okay, all voting on the amendment to delete the 200% of the federal poverty level, all the words after judicial system. If you're in favor, please raise your hand. 1, 2, 3, 4, 5, 6. I'm going to be 7. All those opposed? 1, 2, 3, 4, 5, 6. Okay, 7-6. That one passes. Representative Yin, I think you'll have, well, actually, you won't be on the committee in the spring, but you can send messages in or come visit us. You know where we work. Okay, so that was just the amendment to the amendment. Now let's vote on, is there any further discussion on the original amendment? Representative Clem.
Thank you, Madam Chairman. Not to be a thorn, I'm going to do this. I'm going to offer another amendment. The amendment, as it's written right now, doesn't just limit this to children. So we have a child or parents, legal guardian, or other immediate family member of a child as defined by rule of the Department of Family Services who has been referred to a behavioral health center. So the intent, I understand, is for children to be referred, but this opens the door not just for children, but the child's parent or legal guardian or other immediate family member, could be a brother or sister. And so my amendment to this amendment would be to, after child on that first line, strike or parent, legal guardian, or other immediate family member of the child. And that would be the amendment, just to keep this pertinent to the child only.
Do you want to also take out the definition by rule, or do we need to define children?
I don't know if that's necessary or not, Madam Chairman, at this point. I mean, if it's not necessary, we could take that out, but I don't know offhand.
Okay. Is there a second for the Representative Clem's amendment? Seconded by Barlow. Okay, Representative Barlow, did you have a discussion?
Madam Chairman, so I do think that the as defined by rule is referring to immediate family member. It's used elsewhere in statute, and I think that's what they're defining. The department is often having to define, but maybe I'm wrong. So the director is still with us. I'll make a general comment about this. First of all, I'm not sure about the placement of this entire amendment. I agree with what Representative Scott Clem is doing with this part. Is we're narrowing it down to just the child. And I guess what I would also say as a concomitant, we ought to also strike the and or family's involvement in that fourth line, because that also refers back to other individuals besides the child. So I don't know if it's a friendly amendment to the amendment or just a conforming amendment, but I just want to throw that out there, Madam Chairman.
Okay, and I would also then suppose that we need sort of a typographical is necessary to prevent the child's involvement.
Affirmative, Madam Chairman. Thank
That'd
you.
be correct.
So we're just deleting and or family. We're inserting the and apostrophe S. Okay, any more discussion on this? I guess I have a question, and seeing as there's definition by DFS, not really sure why DFS is involved in the definition now, but I might ask Director Schmidt anyway. So, and maybe I'll just ask on your defining methodology. Let's suppose that we have a situation where family counseling seems appropriate. I mean, I don't know, an abusive parent-child relationship or something like that. One would think that sometimes the parent might need to be with the, that you might counsel them together and not just send the kid in. Could you by definition, I'm a little uncertain as to whether through definition we could expand the child and a problematic relationship that was, if the parent is causative, like they're helping their child sell marijuana or something, maybe it's a criminal case and not DFS. And I don't know. Director Schmidt, do you have any? I think I'm articulating my concern at least well enough for you to respond.
Yes, Madam Chairman, thank you. So the way that the department, and I would think that our crisis services are knowing the providers also do the same, is they look at the family unit. And certainly it's the child's behaviors that sometimes draw attention to the issues in that. And oftentimes it's the children then that are removed. But it's not, more times than not, it's because of family dynamics than it is just the child's behavior. And so I understand the point of the amendment to remove the reference to family, because in some cases there are children, as Mr. Petrie referenced, really high needs mental health kids that with earlier intervention maybe would have been able to manage their mental illness and their behaviors more appropriately. So if you remove the family, that's the kind of kid that I would imagine would benefit from this amendment. If we keep family in there, then it does allow for the family unit to be treated if necessary. It's not always a family issue, but more times than not, it is. So I think just by removing family, you just further define the population that you're trying to serve, which is a child with mental health and behavioral health needs, versus the family unit who that dynamic may create the child's behavior. Does that help answer the question that you were asking?
Yeah, don't know if I like the answer, but it answered it. More discussion on the amendment. Representative Yin.
Madam Chairman, just briefly, could the bringer of the motion repeat the amendment for me? That'd be much appreciated. Thank you.
Representative Clem.
Yeah, thank you, Madam Chairman. So it would be a child and then strike legal guardian or other immediate family member of a child as defined by rule of the Department of Family Services. And then we would also strike on the fourth line after child and or family's involvement with conforming language. Would be to prevent a child or something to that effect in the judicial system. So essentially what we're doing is just narrowing this down to the child and not everybody in the family. So that's the intent.
Senator Schuler. Yep, you're muted still.
Sorry, thank you, Madam Chairman. So then I guess I'm asking the bringer also of the amendment on page 7, on B, line 17, we have that same language. Would that be something we need to look at also deleting? And I don't know that it makes a huge difference, but it's just something that I noticed. Thank you, Mr. Chair, Madam Chair.
I would say just, and maybe Representative Clemens thought about it more, but in that paragraph, we're attempting to prevent the removal of the child from the home. It does seem to me that you really can't do that without dealing with the family. But Representative Clem, do you have any thoughts on that?
Yeah, Madam Chairman, you've summarized that quite well. I mean, this is different. You know, when we're talking about a crisis shelter, which, I mean, these are voluntary placements. And so, for instance, if I wanted to take my unruly child to the crisis shelter here, I could do that. And essentially, without this amendment, then if we had a little family meeting, if my wife was referred to a mental health center, she would now be a part of the priority population. Just right off the street, not knowing anything necessarily about us, we've been referred, and now we're part of the priority population. And so that's where I think it's just a bridge too far. I understand if it's my child, and it's my child would benefit from individual counseling, or perhaps even family counseling or something like that. But it's the child that's really the centerpiece, and the child is referred to a mental health center, that they would be considered part of that priority population. Now, I'm not speaking on the merits of that. I'm just saying this is what this amendment is trying to do, is just narrow it down to the child. I mean, I have some comments about the amendment as a whole, but I think that's really where this specific piece should lie. Whereas the other one, talking about the indigent clients or indigent general access, yeah, we're talking about a different ball of wax there. And so I think those can be left alone, but that's the intent here.
Okay, any further discussion? Okay, so all in favor of Representative Clem's amendment to remove the parent through other immediate family members and the associated language on line 4, please raise your hand. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. I think I got 11. Just let me make sure. Any opposed? 1, 2. Okay. All right. That amendment passes. Okay. Any further discussion on the amendment? Representative Clem.
Thank you, Madam Chairman. So just speaking on the amendment as a whole, I have some reservations about this, although there's some real good merits to this, as far as, and I think I don't know if this is being done currently, to the extent that not necessarily, because we're talking about prioritizing state dollars and spending state dollars on certain services, right? So that really doesn't take place now in the framework that we're talking about. And so my concern with this is, if we're really trying to narrow down, because of our budget constraints, who those priority populations are that we're wanting to serve, then we've just expanded this greatly, because now you're talking about volunteer placements at crisis shelters. And again, as a preventative measure, it's not necessarily a bad thing at all. In fact, it can be quite a good thing. It might be a really, a cost saver in the end, maybe. I just don't know. We don't have the data. But the fact remains is we are really expanding now the scope of who we just consider to be a priority population. And it's not as though that if they're not considered a priority population, that they can't receive services. They still could. If they were referred somewhere to a private agency or something, they'd still receive services. But by putting them in the priority population, we're marking state funds for this priority population for those group of people. Number two, the other thing that really concerns me here is, again, this prioritization is a referral to a mental health center. So again, we're cornering the market on a certain provider or providers to the exclusion of other providers. And we're saying, if you want to take, I'm just playing this out, oh, hey, we can refer you to the mental health center, and now you qualify for state funds to get counseling. Whereas we can't refer you to the private agency over here because they're not considered a mental health center, and you're just out of luck. And we're picking winners and losers because of how we're setting this up by preferring those mental health centers. And so that's where I just have some real unease about this. The motive is great as far as a preventative measure, but how this plays out, I think, really is going to pick winners and losers, and really actually may impact our private providers more than anything else by prioritizing these funds to specifically go to those mental health centers. So that's my reservation. Thank you.
Representative Barlow.
Thank you, Madam Chairman. So speaking to the prioritization, right now we have a general access system that already does that. We already send state dollars to for anybody that walks in the doors would be a priority. What this bill does is set up defined categories. My reservation about this particular amendment, and I absolutely agree that we need to have this discussion, is I think what it does is make children a general access population again. Because the referral is any referral. There is no source of the referral. It could be parent, it could be, and it's justice involved. And anybody knows my family history, I've had my share of justice involved children, one in law school and one not, thank you. So, and the third thing about this general access is we're putting it under a category of families at risk. If we brought this amendment and put it down in a tier 2 or tier 3 and said children, that who have a need, that would be different. But this is the highest category of our tiering system. Remember, these definitions then relate later to our tiering system, tier 1, 2, 3, etc. So my reservation is, one, we're making it, I believe this makes it general access at the highest level for all children. And two, I think it's putting it under families at risk, where if we want to make general access for children a priority, which actually I'm fine with, I'm fine with that. It's what we have right now. I would put it in a different tiering, different category. So that'd be my two comments. I'll probably vote for the amendment, but I have reservations about its placement and its effect. Thank you, Madam Chairman.
I think I saw some more hands. Chairman Scott.
Madam Chairman, let me say I agree with the reservations that Representative Barlow just expressed, and the ones that Representative Clem expressed in terms of how we were broadening this, because I think we are. The reservation about picking winners and losers, I'm frankly, Madam Chairman, we're short enough on providers in this state that I'm not as concerned about that as I might be. I think everybody's got plenty of business, and the problem is we aren't able to afford enough services. But in spite of my reservations, same as I felt about the N amendment, I feel we ought to pass this amendment, and then maybe it can be compromised some because I think we may have broadened it a step or two too far. But I'd rather have the amendment, have the issue clearly on the table with a prejudice in favor of doing something about it, because I think the bill as it came to us didn't quite go far enough in establishing a priority for these kids who can have very severe mental illness. So for those reasons, Madam Chairman, I urge us to adopt the amendment.
Representative Stivar.
Thank you, Madam Chairman. My question is, what will this amendment do with family involvement in the treatment?
So the Clem amendment deleted the family members. So the amended amendment is now on the table. Without the family, although I'm sure by rule there could be some discussion of that. Representative Barlow, did I see your hand?
Madam Chairman, I think maybe I just want to clarify what our colleague Representative Stivar was asking. What the amendment did was take away the parent, legal guardian, all those folks' access to the care. Does not take away their ability to direct the care of their child. I just want to be clear that maybe that's what he was referring to, Madam Chairman. Just a clarification.
Representative Stivar, could you just clarify that question then?
Yes, Madam Chairman. That's what I want to know, is how that's going to affect the family being involved in the child's treatment. Is that going to affect that at all?
I would just hypothesize that we can't affect the family's ability to be involved in the child's treatment. The only thing we affected with the passage of the previous amendment was the ability of the family member to receive treatment as a priority population. Senator Schuler.
Madam Chairman, you know, when I read through this, Representative Roscoe's amendment, I went back and really looked hard at the priority, populations that we talked about. And I sort of felt like it was just really, I didn't see the unintended consequences. And I'm still not sure that I do. I mean, I do see it as a broadening to some degree, because you look at the families at high risk. At A is the ones that have been discharged from a PRTF, and B, the children who've been referred to a behavioral center by DFS, and then this third one. And I agree with the intent. I guess I'm kind of wondering if maybe Director Schmidt could give maybe a little, maybe her expertise on what you think this amendment will do, just to the whole idea of the priority population. Thank you.
Director Schmidt, have you gone to lunch? Oh, nope, she's still here.
Madam Chairman, Senator Schuler, so, in listening to the conversation and kind of, I think, understanding more about the bringer's intent and WISA's position on this, what I read this to do is that we're expanding the circle. So in the amended amendment, we're talking about expanding the circle to kids. Okay, so a little bit about our system. We can serve families in two different ways. We can serve them voluntarily, which are those cases that do not meet the level of a substantiated abuse or neglect, but for some reason they've come to our attention. And the current legislation, proposed legislation, gets at that population. And that population is really important to us because there's a good portion of families that go into the court system because parents need mental health and substance abuse services, right? So we're working with this voluntary population, and anywhere from 37 to 40% of those families, we remove the children eventually because of parental mental health and substance abuse. So that is the huge importance to our system about focusing on those families as a priority. But when you start to expand it, then you're doing just that. You're taking the state dollars and making decisions about who to spend those state dollars on. And now you've broadened the pool to include children who are referred from any source, right? And so what causes me some confusion is not the principle of it. I understand the principle and the prevention aspect of it and fully support it. Where I think it gets confusing is kind of in the bureaucratic side of it, as Senator Scott mentioned. It's how is it that the community mental health centers and substance abuse centers know that child is now a priority population because every child that comes in is. And then if you do have a family that needs services in conjunction, then you're having a child that's covered under the contract with the behavioral health division, and then looking for a way to pay for the services for the parents. So then is that then private pay or insurance or what have you? So it's more devil in the details for me, but that's because I sit in an administrative position. However, I do fully understand and embrace this idea about if we can get kids into services earlier when they're starting to show some signs, which is in this, the example here, when they're in a crisis shelter, right? There's something happening that said that kid, the parents needed to voluntarily replace that kid. Yeah, there's something happening there, but I can't tell you if it's solely related to the child or if it's related to the family. And we honestly don't get involved at that point. It's when it gets a little bit worse than our system kicks in.
Senator Bouchard.
Yeah, I have a question for Ms. Schmidt. If a child comes through your agency with a problem like this, does it come out of more of federal funds or out of state funds?
Director Schmidt.
Madam Chairman, Senator Bouchard, so the funding that goes to families and children as a result of our involvement typically break down into 65% general fund, 35% federal fund. And it really depends on the qualifications of the family, the eligibility of the family when they come to our attention. So we use TANF dollars and we use 4E dollars, and both of those have financial criteria applied.
Chairman Bouchard, or sorry, Senator Bouchard.
Thank you, Madam Chair. Well, just a follow up then, I'm concerned that when we do expand in this bill, that we would be competing, and that's not the right word, but I obviously don't want to set up a situation where we've got the health center getting the funding somewhere else where they could have went through, where this could have went through your department. So that kind of sets a red flag up for me. Would you agree that could be a problem?
Director Schmidt.
Madam Chairman, Senator Bouchard, I think what you're asking is, would our dollars then be used for those services that otherwise would have been paid for with the Department of Health contract?
No, Madam Chair, Director, what I'm worried about is people being funneled a different direction, money spent out of a different pot instead of maybe they could have went through money that was at your agency. So we've reprioritized them away from a program that you have. That's what I'm concerned with.
Director Schmidt.
Madam Chairman, Senator Bouchard, so now I think I understand the question. So if we have a family then that is involved with DFS where the removal hasn't occurred, so that family unit, we do not have funds to serve that family unit. So we're relying on the Department of Health's contracts to serve that family unit. And what this legislation does is says to the community mental health and substance abuse centers, this population is a priority because if we don't serve them, there's risk that they're going to come into care. If a child then comes into care, if the court says we're removing from the home, then the dollars that we have are still not for parents, they're only for the children. So we're in fact still relying on the Department of Health contracts with those behavioral health centers to provide those services to those to the adults. And that's why that prioritization is so important to us, is we don't right now have funds to provide a lot of treatment for the grown-ups in the situation. Once they come into care, we have money for the kids, but not for the adults.
Representative Hallinan.
Thank you, Madam Chairman. Director Schmidt, how many of these children are there that are in these emergency referrals? And what is the percentage of those children are referred to the behavioral health service for mental illness and the other listed items in this bill? What's the percentage of those children? And how many are there?
Director Schmidt?
Madam Chairman, Representative Hellinan, I think I'm going to try to answer this question, but I believe that Mr. Birkeland is probably in a better position because we don't track all of this data. But we have, according to what information we served from the crisis centers, we served 15,000 families. Does that sound about right?
Mr. Birkeland?
Probably 1,500.
Oh, okay. And then to the extent that they received behavioral health services or referrals, I would defer to Mr. Birkeland for that information.
Mr. Birkeland?
Madam Chairman, Representative Hallinan, I would say yeah, a majority of those family and youth are probably, well, I'll back off of that majority because probably a third of those are treated within those centers where they have their own therapist, so they don't need to go to a counseling center. And so the rest, the vast majority of the rest would probably be referred for treatment, but there's also a number of them who would be on Medicaid or have insurance that would not need to take state funds. So I think, you know, that I would need to gather a lot more data to put a hard number to that, but I think you're looking at a few hundred.
Representative Clem?
Thank you, Madam Chairman. So this one is for Director Schmidt or Mr. Birkeland. I'm concerned that we're quite possibly setting up a conflict of interest with a mental health center. And I'm just thinking about my own community and the Yes House here. So the Yes House would or could be considered a behavioral health center that would utilize these funds for priority populations. They also are the ones who run the crisis shelter. And so the conflict that I foresee here, and this is where I'd like to know if I'm off base or if indeed there could be a conflict, is if we expand the population to any child from a crisis shelter and the crisis shelter staff, they have their family meeting, and let's say they normally would say, hey, look, you know, your child could benefit from counseling, right? They may refer to the Yes House. They may refer to a private provider somewhere, you know. But in this case, if now they're considered part of that priority population that receives these state funds, my concern is that doesn't that kind of just funnel kids into, you know, your own agency if you're the one who runs the crisis shelter and you are the community or the behavioral health center? And isn't there kind of a conflict there? That's what I'm trying to figure out. So Mr. Birkeland or Director Schmidt, if you two can help me out, I'd appreciate it. Thank you.
Director Schmidt, do you have any thoughts on that?
Madam Chairman, no, I don't. This gets into a treatment appropriateness level and referrals to self. So I'll defer to Mr. Birkeland.
Mr. Birkeland?
Madam Chairman, I imagine that I just it could happen. I have not ever seen any issue within the crisis shelters or between the community mental health centers where the crisis shelter is trying to be a behavioral health center, or that there's ever been any particular conflict I'm aware of and competition between that. So I imagine it is possible. I don't think that's likely.
Thank you, Mr. Birkeland. Senator Bouchard.
Thank you, Madam Chairman. I have a question for Mr. Birkeland based on the 1,500 families that received services. How do we prioritize now? And I'm really taken back that we're making a decision and we haven't talked about how much money that is. So I'd like to know how much money that 1,500 families, how much we're talking about here.
Mr. Birkeland, and we understand you may not know that part, but.
Madam Chairman, you're right. I would not be able to put a dollar figure on that, but as I said, I mean, presently, I think that was a question some time ago of what happens at the present time. And the present time, that's the concern, is that a certain percentage of these families that come through the crisis shelters get individual or family therapy through the community mental health center, and is an important part for their treatment. And a percentage of those people do need to rely on state funding that the community counseling center gets, and that they're not on Medicaid, they don't have insurance, they don't have the income. But that's, and I'm not sure what that percentage is. I do not think it's a majority, but it's an important number. I think in terms of the questions that, and another issue just that have come up about the referral source, I think that's something that could be narrowed. When I thought and talked about this, I didn't want to just say referrals from crisis shelters, but that was the primary thing I was thinking of. I was trying to be more, not assuming that we're the only people that see the kids in this situation, but that would be a possibility too. So.
Okay, committee, I will just remind before we wrap this up that remember, we do require the general funds to be payer of last resort. So, this is on page 14, paragraph 3. So if a patient, or a person has insurance or Medicaid or something, even if they are a priority population, the center will have to bill the insurance for this person. And then Senator Bouchard, I saw your hand, and then folks, I think that we need to, I'm not sure that we can get everything pinned down on this. I am curious after Senator Bouchard's question to kind of move on to a vote, with the thought being that whichever way it goes, I think there can be further conversation during session when we've gathered a little bit more thoughts. And if we don't vote for it, we may put it in, and if we do vote for it, it may be amended. And I think that's okay, because I'm not sure that we can actually resolve all of this right at the moment. But Senator Bouchard, your question. Yeah, you're muted.
Sorry, Madam Chair. I was trying to signal you that I was good. So.
Oh,
I'll just pass.
Are you going to do like one of those football things, and I don't always know what's happening. You're good. Okay. All right. Then committee, let's go ahead and just take a vote on Mr. Brody. And Mr. Brody, oh, there you go.
Thank you, Madam Chairman. John Brody, LSO. I just wanted to raise a few points for committee consideration on some potential ambiguities in the amendment. The first being this idea that a child be referred to a behavioral health center. It's kind of been touched upon in the discussion today, but this sounds like a requirement without really any direction, in the sense that we've had discussion about self-referrals. So I don't know if the committee's intent is that there acts, some sort of more formality to a referral, or if it's just simply a child seeking treatment from a behavioral health center. So just one point to bring to the committee's consideration. A second point being the reference to an illness or a disorder that impacts a child. That's a very ambiguous phrase right there. And I don't know, obviously reasonable people could come to different conclusion on what an impact is. Really the hinge of that paragraph is that it's necessary to prevent the child's involvement in the justice system. So it may be simpler to just simply remove that wording and not create the potential for confusion or disagreement as to how this provision is going to operate. And then the last point I just wanted to raise is the idea of a judicial system. In our state statutes, we refer to the state judicial system, we refer to the criminal justice system. So I just wanted to raise that as we state judicial system, that really can have a number of flavors I just want to make sure that the broadness of what that term seems to imply is the committee's will. So thank you, Madam Chairman.
Okay. I think it's clear that whether we pass it or not, this might need a little bit more work, and we can vote accordingly. So all those in favor of the amendment as amended, please raise your hand. 1, 2, 3, 4, 5, 6, 7. All those opposed, please raise your hand. 1, 2, 3, 4. You know, I think some people sort of have their hands maybe down, raise them again, just put them way up by your face. Some of you, depending on how you've got your camera aimed, I can't always see the hands. Okay, those in favor, again, those in favor. 1, 2, 3, 4, 5, 6, 7. Okay, those opposed? 1, 2, 3, 4, 5. Okay, so that amendment has passed. Representative Roscoe is not going to be on the Labor Committee again in the spring either, but that's all right. You can always come visit, send in notes. We've got the amendment as it is. We might work it over some more. Okay, are there any other amendments that were not sent in as requested? We seem to have a lot of hands. Really, guys, I asked you to send them in. Representative Ian.
Madam Chairman, my apologies. I will say that I'm still very concerned about Teton County folks, and as such, I'd like to make a motion to amend on page 8, line 12, to change the 100% of the federal poverty level to 150%.
Is there a second? Seconded by Sweeney. Okay, any discussion? Representative Yin.
Madam Chairman, thank you. Yeah, so I think I expressed this concern at the last meeting, but essentially, you know, we're kind of overhauling how we deal with mental health issues. And I think there are a lot of members of the Teton County community that receive mental health services under the current block grant system, but would probably not be in the priority list at all with this new bill. And so I like to have some effort to try to include more of those folks, and it still would be in the lowest priority of indigent general access clients. In my opinion, I think this helps just keep some of those people in the types of people that we want to serve, even though they're still at the bottom of the priority list. So if our budget can't afford it, they'll still be at the bottom. Thank you, Madam Chairman.
Chairman Scott, did I see your hand? You're muted still. Co-Chairman Scott.
Madam Chairman.
Oh, there you go. Okay.
Madam Chairman, I'm having trouble because sometimes it won't unmute with the standard procedure.
It didn't seem like me doing it either.
Madam Chairman, on and against this amendment, the 100% makes a lot of sense, because if they're under 100%, then they're not eligible for funding through the Obamacare exchange, can't get on it. If they're 100% of poverty, if they're over 100% of poverty, they can and should have insurance. It's there and available to them. So I think that this amendment would broaden the ways and spend general fund in a way that's probably unnecessary for the people to actually get services.
More discussion? Okay, all those in favor of the amendment, please raise your hand. 1, 2, 3, 4. Oh, wait a second. Some of you on top raised your hand afterwards. Keep your hand up. 1, 2, 3, 4, 5, 6. I'm 7. Okay, all those opposed? 1, 2, 3, 4, 5, 6. We must be missing Senator Baldwin again. All right, that one passes by 1 vote, 7-6. Okay, let's see. I saw somebody else have their hand up for an amendment. Representative Stivar.
There's a lot of questions on this bill. I want to put amendment as a sunset date on this out to 2026. Then we could revisit it and make sure it was done the way it was intended.
Okay, is there a second? Seconded by Senator Scott. Okay, any discussion? Senator Scott? Senator Scott, did you have some discussion?
Yeah, Madam Chairman, this amendment made a lot of sense to me. This bill is in response to the financial crisis we've got right now. I think taking another look at it 6 years out makes a good deal of sense, and would urge adoption of the amendment.
Okay, any further discussion? Okay, all in favor of this amendment to put on a sunset? Sure, Mr. Brody.
Sorry, Madam Chairman. Just wanted to point out that the bill does have a 1-year delayed effective date. So I guess maybe I'm stating the obvious, but it wouldn't have a 6-year sort of time to play out. That time would be a little bit more abbreviated because there is a kind of background work that the Department of Health has to conduct before the bill even really goes into operation.
Okay. Senator Baldwin, did I see your hand? No. Okay. All right, all in favor of the amendment, please raise your hand. 1, 2, 3, 4, 5, 6, 7. All opposed? 1, 2, 3, 4, 5. How am I missing 2 people again? I'm gonna vote. I gotta vote again. Okay, all in favor of a sunset date, raise your hand and keep it up. 1, 2, 3, 4, 5, 6, 7, 8. Now there's 8. I better count again on the opposed because who knows, now there'll be 9 of them. How many opposed? 1, 2, 3, 4, 5, 6. Okay, that amendment passes. Were there more amendments? Representative Clem.
Yeah, thank you, Madam Chairman. This would be page 14, lines 13 through 20. Delete all new language, reinsert old language. This goes to prioritizing the behavioral health centers. And so just trying to revert it to what it was. I totally agree with prioritizing how we spend these funds and priority populations. I think that's a wise and good move, but when we start prioritizing behavioral health centers, and that really is, in my opinion, picking winners and losers. And that's the thing that concerns me, is that we're going to have the state pick which facilities get these funds, these priority funds, and get subsidized versus others who don't. And so that's the intent of the amendment, and that's what I would do. Just, yeah, thank you, Madam Chairman.
So let me just, if I can, to read the paragraphs. I'm sorry, is there an amendment or a second? Seconded by Bouchard. Okay, I'm just going to make sure to read the paragraph to make sure I grasp it with all the things. So the strikeouts added back and the underlines deleted. So it would say, for state purchased services, select the most appropriate service providers within each region in order to achieve the most effective and efficient human services system. Did I read that basically right? It was a little bit confusing. Okay, so I just want to ask a question of Director Schmidt, or no, Mr. Where's my Department of Health people? Have I lost them? Mr. Fuchs or Mr. Petrie. Let me just make sure we understand. So did you hear the amendment?
Madam Chair, yes, I did. I think that, at least from my perspective, I think that the language as it stands now, lines 13 through 20, allows for the community mental health centers and the state to provide funding in instances where it's necessary because those services can't be provided by those community mental health centers. I guess my concern would be that without some type of prioritization, especially with the contracting process that we go through in order to essentially procure these services, that it would just become very complicated and possibly even burdensome if we don't essentially limit the number of community mental health centers that that this legislation applies to.
So currently, do you go out with an RFP, and would that be your intention still, that for these services, for whatever the contract period is, 3 years or something? I mean, what is your, just clarify for us what the process is of deciding where to put these general funds.
Madam Chair, thank you. I may defer to either Andy Somerville or Ben Kiefer on this question, but in general, yes, there is an RFP process. We typically see essentially the same community mental health centers, the same provider groups that express interest year to year, and the contracts currently run for 2-year timeframes. They have to be, to some degree, they have to be in a position where they can provide a fairly wide array of services, and so in some respects that's probably to their advantage through the RFP process. But again, I might defer to either Andy or Ben if they had anything to add to that.
So if you didn't, when you put out the RFP for the contracts, presumably you identify the deliverables. I mean, the capacity of a certain level of mental health and various services. If you're not prioritizing the behavioral health centers, what are the other options for your decision making on how to award the contract? I mean, would you hypothesize awarding them based on low price, or what would the other possible decision points be?
Madam Chair, thank you again. I think that it's not necessarily on price, because the way that we pay through the contracts for the community mental health centers now, the price for services.
I'm sorry, you fell off, but I suppose you're going to say
differ from center to center, and so it really, I think that it is primarily driven by the scope of services that they can provide, and the the array of services that they can provide.
So you're putting out a request for a proposal to provide an array of services for whatever, you might say $3 million, let's say, or something like that, and they send in a list and say, this is who we are, this is what we do. And if you, right now, if you got, let's just suppose in Natrona County, you got 3 bids. I mean, I don't know if that ever happens. Maybe you only ever get 1 anyway. But if you got 3, how would you decide?
Madam Chair, thanks again. I would have to defer to Ben Kiefer. the section head of the mental health and substance abuse section for that.
Is he here?
Typically, yes, he is. Katie, could you allow Ben into the Zoom meeting?
Go ahead, Katie.
Madam Chair and Mr. Petrie, he is in the room. He is in the meeting.
Okay.
I don't see his rectangle. We're gathering so many people. He might be on a second page. Oops, he must be on my page 2. Wow, the group has enlarged. Mr. Kiefer.
Yes,
So
Madam Chairman. Yes, ma'am.
Yes. So I don't know if you heard the discussion. Supposing now, I don't know if you typically only get one proposal per county, or let's say I'm just making something up, but suppose in Natrona County, you put out an RFP and said, we want these various services for $3 million, right? I don't even know what the amount is. And if you, let's say, got 3 proposals, how would you decide to whom to award the contract?
Well, Madam Chairman, we put out the RFA for application. The application lists out those services and what can be offered and what constitutes a community mental health center. They will apply for these services, which they have available. And if those services are comprehensive in nature and they're able to deliver those core services better than another applicant, and that's how they're selected, not by cost. But typically, now I've only been here for one contract cycle. So we typically do not see many competitors when we put out application. And in most cases, they are either self-eliminated through certification processes if they don't have CARF, if they don't have the level and amount of providers or services available. There's a whole gamut of probably reasons why. It would probably be case by case. But again, typically, the competitors that we do see cannot supply the amount and types of services that the community mental health centers traditionally have. If that helps.
That is informative. Thank you. Questions for Mr. Kiefer before we have further discussion on this amendment? Representative Clem.
Thank you, Madam Chairman. So I appreciate the explanation as far as how are things currently prioritized. So assuming that given the changed language here, the language that's in the bill to prioritize behavioral health centers as providers of the state funded services, how would that change then the current process? I guess because I'll just leave it there. How would this change as far as prioritizing? Because it sounds like there is an existing way that things are prioritized as it is. So we have something that's there that works. What is broken about that system, and why do we need this change? Thank you.
Mr. Kiefer.
Madam Chairman, Representative Clem, to my knowledge, I don't see the impact or change that this language would have. In general, these providers are already prioritized by virtue of just having the comprehensive services, being CARF accredited, being large enough to supply the services on a regional basis. Again, this is a case by case. And in that way, they are prioritized or exclusive, if you will, because they have those eligibility requirements that are a part of our rules and application.
Okay. Any more
Madam
questions?
Chairman, just to follow up on that. So then do we need this new language at all if that is the existing process and it works?
Mr. Kiefer.
Madam Chairman, Representative Clem, I couldn't answer that definitively. At first glance, I would say no, because the process already does that. But again, if that needs to be clarified in the bill, then I would support that.
Okay. Any more questions for Mr. Kiefer? And I apologize, now I'm up to 2 pages. So if you're trying to get my attention and I don't see you, then you might have to put up your little blue hand. Representative Hallinan.
Thank you, Madam Chairman. Mr. Kiefer, are there currently any cases in a county where there are two applicants for these contracts now? Have there been any in this final year, in this last year?
Mr. Kiefer.
Madam Chairman, Representative Hallinan, I probably should have clarified my previous statement. Yes, when you have two applicants and they are both eligible, that decision goes to the county to make that selection. And that has happened, I believe, in the past, but not in my time in the seat.
To the county commissioners, you mean, Mr. Kiefer, or who?
Correct, to the county stakeholder groups. Yes, ma'am.
Ah, this is getting more involved. Any more questions from Representative Clem?
Yeah, thank you, Madam Chairman. So that does bring up an interesting point, because then are we actually usurping that local control by inserting this new language? It would seem that that's what we're doing. We're saying that the state's going to make that decision versus what the local stakeholders do right now. Is that a fair statement? Thank you.
Mr. Kiefer, do you feel like you're a little on the witness stand, Mr. Kiefer? Well, you are, I guess. So,
thank you, Madam Chairman. I apologize, Representative Clem. Could you restate that?
Yes, Madam Chairman. So if you have two entities who are competing in a county and it's the county that gets to decide, those local stakeholders, then it would seem that this new language that has the state, or the department rather, to prioritize behavioral health centers as providers of state-funded services, it seems that we're shifting. It's a shift in state policy. We're saying that it's no longer the local stakeholders that gets to make that decision. It's now the state. It's now the Department of Health. With the new language, would that be correct?
Madam Chairman, Representative Clem, if that's the way the new language is interpreted, then yes, that would circumvent that.
More questions for Mr. Kiefer? Mr. Brody, are you raising your hand?
Madam Chairman, I don't have a question for Mr. Kiefer, but just a point to raise to the committee.
Oh, go ahead. What is your point?
Thank you, Madam Chairman. John Brody, LSO. I just wanted to ask the committee's consideration of the interplay between the paragraph that the Clem Amendment is dealing with and paragraph 10, which deals with the essential subsidy payments. The operation of that paragraph hinges on services being provided by behavioral health centers as contracted by the Department of Health. It sort of functions as the trigger to be eligible for that subsidy payment. So there's a bit of interplay, and I think I'd just like to get some direction from the committee on how to deal with that.
So, Mr. Brody, I'm only looking at this in about a 1 second thing here. I'm not quite sure. I guess I'm not quite sure what the concern is, because the department shall provide essential subsidy payments to behavioral health centers or to other eligible service providers. I mean, I see the connection, but it doesn't seem like, I guess the only thing that you're saying, are you just saying that if we actually, because if we strike paragraph 6, the existing language still remains and would still feed line 21 of that. Can you help me there?
You get it right.
But I mean, I guess I'm more just bringing it up to make sure that LSO moves forward with the intent of the committee, in the sense that these essential subsidy payments were being provided to support this system of a behavioral health center providing state-funded services. If this concept of behavioral health centers leading the charge on state-funded services is no longer part of the bill, perhaps it's worth consideration of whether the essential subsidy payment is necessary or not. Also, the reference to other providers, the other providers are eligible for the subsidy payment under the provision the Clem amendment will deal with only if they're selected by the Department of Health because a behavioral health center cannot provide the range of services that are necessary. So I guess I want to raise the fact that this potentially could open up paragraph X to a lot more providers as far as eligibility for the essential subsidy payment. And maybe that's okay. I just wanted to raise it.
Okay, any more discussion? I'm trying to check both of my pages here now. Any more discussion? We've brought up a number of issues here, which I'm not sure we have clarified. And I'm
Madam Chairman.
Representative Clem.
Yeah, thank you, Madam Chairman. So indeed, we have raised a number of issues here. I believe, and I looked at that as well as far as paragraph 10 before making that amendment, because I had that marked down on my sheet as well. That being said, paragraph 10, again, subject to the priority populations tier requirements, that's really what it's subject to. They can give those contractual payments to behavioral health centers and other service providers under this act. And by changing that paragraph 6 on line 14, really does, I mean, their behavioral health centers are still chosen, or other service providers, if there is a behavioral health service or a behavioral health center that doesn't meet those qualifications or can't provide those services, another service provider still qualifies. Nothing changes. So I don't see any issue as far as the interplay between paragraph 6 as it is right now with the new language, or reverting back to the old language. I think the mechanism is still the same. The key, and that's what we heard, that this is essentially the process already. But what we've uncovered is that there is a big shift in state policy, and in that, if there are 2 or more competing entities in a county, the practice right now, the policy of the state is for the local stakeholders to select that service provider, that local control that they know best. And there's some accountability there as far as those local stakeholders in responding to constituents. This shifts that to the state. And it takes the local stakeholders part of that out of the equation. That's what I understand this to do. And so again, the mechanism, that's why I wanted to go back to the old language. In all reality, it's not going to affect anything other than letting those local stakeholders have a say in this. So I would urge adoption of this amendment to go back to the original language.
Okay, are we ready to vote on this amendment? I'm just checking both pages now, because as I say, we're up to 2 pages somehow. Hang on. Okay, so if you are in favor of the amendment striking paragraph 6, which would strike it from the bill but revert it to the existing paragraph 6 in statute, please raise your hand. And if you can leave it up, please, because I have to check 2 pages now. 1, 2, 3, 4, 5. Oh, wait a minute. Some people have changed. Hang on. This is going to be just, you know what? Mr. Brody, I'm going to have you call the roll, because when I switch pages, some people's pictures switched pages. And now I'm counting you twice. Mr. Brody, could you just call the roll on that amendment, please?
Madam Chairman, this is on the Clem amendment, page 14, lines 13 through 20, to delete paragraph 6. Senator Baldwin.
No.
Senator Bouchard.
Aye.
Senator Pappas.
No.
Senator Schuler,
No.
Representative Barlow,
No.
Representative Clem,
Aye.
Representative Dayton Selman,
No.
Representative Hallinan,
Aye.
Representative Roscoe,
No.
Representative Stibar,
Aye.
Representative Sweeney,
No.
Representative Ian,
No.
Co-Chairman Scott,
No.
Co-Chairman Wilson.
Aye. Okay, so that amendment has failed. Thank you, Mr. Brody. Okay, are there any other amendments to this bill? And again, I'll try to check both pages. Okay, I don't see any others. Scream and shout if I missed you. All right then, Mr. Brody, would you please call the roll on the bill?
Madam Chairman, this is on whether the committee will sponsor 21 LSO 225 version 12 as amended for introduction during the 21 general session. Senator Baldwin.
Aye.
Senator Bouchard.
No.
Senator Pappas.
Aye.
Senator Schuler.
Aye.
Representative Barlow.
Aye.
Representative Clem.
No.
Representative Dayton Selman.
Aye.
Representative Hallinan.
No.
Representative Roscoe.
Aye.
Representative Stibar.
No.
Representative Sweeney.
Aye.
Representative Ian.
No.
Co-Chairman Scott.
Aye.
Co-Chairman Wilson.
Aye.
The motion to sponsor has passed.
Okay, thank you. All right, committee, just to let you know where we're at on the bills that we have passed through the interim. Incoming Chairman Baldwin and I will put our heads together and assign them out to the chambers. We've got significant turnover in both committees, and we need to contemplate a little bit where we will shuffle them out. However, and incoming Chairman Baldwin, are you there? I'm not sure if he's there.
I'm here physically, if not mentally.
Oh, there you are. Senator Baldwin, if you and I can get together this week, just so that the LSO can get those bills out the door and labeled, I'm sure they would appreciate it. Will that fit with your schedule?
That would be great. Why don't you just give me a call any night this week? It would be fine. Tomorrow, tonight, whenever you want to call me, we'll figure that out.
All right, and I have the list already from LSO of what the ones are. We don't have too long of a list, committee, but some of them are fairly substantive. So welcome aboard to any new members who are listening. We'll have that list tidied up in a while, and we might be able to sort of ship them out before session sometime, whenever the session will be. Co-Chairman Scott, do you have anything to say at the end of the meeting before we adjourn?
Madam Chairman, just wanted to say that it's been a pleasure working with you for these past few years. And I've promised incoming Chairman Baldwin, I'll do my best to be supporting him, particularly on the floor, as particularly as some of these bills come up. Some of them are works in progress, but I think they're pretty important. I'll miss those of you who are leaving the legislature. Thank you for your service. And the rest of you, whenever we get to Cheyenne, we'll see you.
Thank you, Co-Chairman Scott. Last meeting, of course, we thought it was going to be the last meeting, so I particularly thanked Vice Chairman Clem for his service to the committee and Representative Dayton, who served with me a long time. Now we've got so many other shufflings that if I tried to make a list, it'd be sort of like the Academy Awards or one of those things. So I won't. But looking forward to seeing everybody again and the new folks, and those of you who are departing, stop by when you can. We know that Cheyenne in January is not the most delightful of places, but perhaps you might pass through on I-80 or I-25 sometime in the warmer part of the year and visit me. I'm here. So anyway, and thanks very much again to LSO. It's been quite a summer. I know LSO has had to learn a lot more skills and wear a lot more hats and make everything work. And we certainly couldn't have done it without you. And thanks very much to all of you. And we'll see you again when we can. And the meeting is adjourned.